Nilima, because there are people waiting in the room. Parag, can we start?
Yes. It's 4 o'clock sharp.
Good evening to all. We would like to invite you to this online certificate course on labor and birthing. And it's an opportunity given by ICOG to all of us governing council members and members of FOGSI. And extremely honored to have the President FOGSI would be joining a little later, Dr. Sunita Tandulwadkar. I also like to welcome the chairperson, Dr. Parag Biniwale, who has worked so much, he's helped us in every way whenever we had a problem, and he's helped in the management of the program also. I'd like to welcome the Vice Chairperson-elect, Dr. Ashok Kumar, the Secretary General of FOGSI, Dr. Suvarna Kadilkar, the Secretary of ICOG, Dr. Sarita Ballarao, all the conveners, Dr. Poonam and Dr. Reshmi, the coordinators, Dr. Umayal, Dr. Kavita, and Dr. Monica, esteemed faculty who have joined today, the chairpersons for all the sessions, respected delegates who have given you a valuable time to join this program. We request that you interact with us at the end of the program also. And also I would like to thank the effort given by the tech team as well as ICOG office, particularly Dr. Ms. Nilima, who's helped us with this program at every way. Thank you so much for that. Can we have the prayer song? Thank you, Nilima. Can I have the next slide, please? It's an honor to welcome the President of FOGSI 2025, Dr. Sunita Tandulwadkar, as well as Dr. Parag Biniwale, the chairperson of ICOG. He's been a PG teacher and unit head from Kamala Nehru Hospital. And we would also like to welcome the faculty from all over India who have come today. May I have the next slide, Nilima? Next. Before this, yeah. So the program will be for 3 hours every day, and it will be we'll have sessions one after the other. We may not have time for interaction. There is a post test at the end of the all the sessions today, and you need to attend that post test assessment, and that will be for 10 minutes. And once you attend, you are supposed to attend for the next 2 days also. And you need to have a pass mark of 50%, and you will get a certificate from ICOG, and it will be sent to you within 1 month. And suppose you want to interact, we request that you wait after the post test, and people who have time can wait, and we can request the faculty to answer your questions. Otherwise, if there's no time in between the sessions, we request that you forgive us, because the sessions are going to run next, and we don't want to extend our time. And it's a earnest request to all the chairpersons to introduce all the speakers in 1 or 2 lines, which will give them, which will help us to run the program very, very smoothly. And I now request Dr. Poonam Goyal, the convener for the first day, to start the session. Thank you so much. And we have to request Dr. Parag Poonam to give his address after you welcome. Yeah.
Okay. So I welcome Dr. Parag sir first to address the gathering, and then I will just give the introduction to the course today.
Thank you, Charmila and Poonam. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to be talking to you for this certificate course on labor and birthing. When we were thinking of having a program, Dr. Charmila came up with the idea that we should have a program, and in fact, she had given an extensive program which lasted for almost 4 hours every day. But then looking at the trend, we had to trim it to 3. And Charmila, let me assure you that whatever we have missed, we will take it up a little later as a master class. So, we don't want our delegates to be deprived of some interesting topics. First of all, let me thank and congratulate the conveners for this program, two of my governing council members, Dr. Charmila and Dr. Poonam, and Dr. Rashmi Kahar, who's the chairperson of Practical Obstetric Committee, and the coordinators, of course, Dr. Umayal, Dr. Kavita Bhatti, and Dr. Monica Umbardand. For next 3 days, we are going to have long discussions and learning on different aspects of labor and birthing. This is something which obstetricians need day in and day out, and we've handpicked the faculty who are really experts in it, and they would give us some important take-home messages, which in fact would translate into a better clinical practice as far as labor and birthing is concerned. And obviously, it will definitely have a positive impact on our outcome of a patient, and that will help our women who come to us for labor and birthing will be benefited. So happy learning for everyone, and please do not hesitate to ask your questions in the chat box. And my request to all the faculty, please answer all the questions which are there in chat, because a time constraint of 3 hours doesn't permit us to have one-to-one interaction, but please address all the questions which are put in the chat box so that the delegates who have their queries in mind are satisfied. Thank you very much, and my best wishes to my team and all the conveners. Thank you.
Thank you so much, Dr. Parag sir. So I think we can go ahead. Welcome all the delegates and warm regards to all faculty who have spared their time for today's discussion. Today we are starting the course on labor birthing, and it is an ICOG initiative. As you all know that ICOG is academic wing of FOGSI, and knowledge distribution and skill enhancement is the main goal. Dr. Parag is a visionary, very methodical, and a very sorted out person, and we are expecting a great work from him and new milestones this year. So being obstetrician, we all have navigated the intricacies of labor countless number of times, and yet the landscape of maternal care is undergoing a transformation like never before. Now we are talking of respectable maternal care, and we have better ovulation induction options now. Role of AI has now become very important. So today we will be covering the phases of labor, that is normal physiology, then latent labor, then something very important, that is arrested labor, and then most important is exploring the role of AI in analysis and precision driven obstetrics. So Dr. Charmila has a vision, and she has brought three very important speakers from the institute, that is THSTI, that is Translational Health Science and Technology Institute, who turns concepts into the products to improve human health. So we have heard Dr. Bengal today, who will be speaking on birthing positions. And in the end, we will have a fruitful panel discussion on induction of labor. So let us all work together for the safe and optimal outcome of the every labor. So starting on to our first session, our chairperson is Dr. Kiran Pandey. I'm not sure that she has joined. I don't think she... Dr. Kiran, are you there?
Poonam, you continue.
Okay. So our first speaker for today is Dr. Saraswati. She'll be speaking on phases of labor. She is from RK Hospital for Women and Children, that is from Thanjavur. So Dr. Saraswati ma'am, welcome. Please share your screen and let us move forward.
Saraswati madam, you're joined?
Yeah, I've joined.
Okay,
Can you
ma'am.
hear me?
Yeah, we can hear you. Please share your screen, madam.
I'm trying to.
Nilima ji, please help her if there is any problem.
Yeah, Dr. Saraswati ma'am, just open your presentation.
Yeah.
And click on share screen button on your
Screen
screen
button below.
and select your presentation.
You already have your presentation downloaded, no, madam?
Yeah,
It's
I
the
have
screen.
it.
Okay. Do it slowly, no problem.
Having some problem. Just a moment.
Okay.
Some delegates are asking in the chat box about the pre-test. So there is no pre-test, but there will be a post-test of 20 questions after the completion of the session.
Saraswati madam, can you send it to me other way? Okay, it's started.
Yeah.
But your presentation, yeah.
Can we move forward to the other?
Madam, is it okay if we go for the second talk and you can just see whether your presentation is working?
I'll get it ready in a moment, ma'am.
Okay. Should we wait for you or can you go to the second talk? It's
Okay.
open. It's working.
Great.
Make it into a slideshow, ma'am. Yes, yeah.
Sorry for the delay I caused, and
No problem, madam. Please start.
good evening to everyone who's there waiting to hear the talk. And I bring greetings from the temple town of Tanjavur, right at the middle of Tamil Nadu. This is the famous capital of the Chola Empire, which was made even more famous after the movie Ponniyin Selvan. And Tanjavur boasts of the 1,000-and-odd-year-old Bragadishwara temple, which is a monument to be seen in case you have not seen. So with this, I would like to start my talk. At the outset, I would like to thank our dynamic and ever-inspiring Vice President, Dr. Charmila. Dr. Charmila has been working very, very hard for the past 1 year. Ever since she prepared taking over as Vice President. And for the past 2 days, I've also been observing how the ICOG team has been working so hard. They've given so much of their time and energy to organize this workshop, the certificate course. And I would like to thank them for their appreciation. And without wasting much of my time, let me go on to the talk. Labor and delivery should end in a safe manner, which should ensure that a healthy mother and a healthy baby are obtained as an outcome. So it is very important that the caregivers for the laboring patients have a robust knowledge of the physiology of labor so that they can vigilantly monitor a patient in labor and also step in whenever there is an abnormality in an apt fashion to obtain the goal for which they started the process. But it is also important, as the speakers were saying, that we must understand that the demographics of the pregnant patients have been changing over the years. Women opt to get married late, want to start a career and put the career in front of childbirth. So childbirth is delayed to a later age, adding to the complications. Obesity, medical and surgical comorbidities are also increasing.
Madam, sorry to interrupt. The
Slides
slides are
are
not
not
moving. Not moving, ma'am.
Yeah. I'm not into the next slide yet, ma'am.
Okay. No, sorry.
So a risk assessment has to be more vigilant so that interventions can be apt to obtain the outcome that we want. An understanding of the relationship between the fetus, its presenting part, the uterine contractions and cervical dilatation over the time is important so that the obstetrician can watch the progress and intervene at an appropriate time. So how do we understand this relationship? It all started with the Friedman's curve. Emanuel Friedman in 1950 studied 1,500 women in labor, and with the data, he formed this curve, which has a series of slanting lines and sleeping lines. And these lines put together tell us that a laboring woman has a latent phase and an active phase. The latent phase in a primigravida is about 8 to 12 hours, whereas it might be shorter in a multis, about 6 to 8 hours. This is the phase when the uterine contractions start, but they are not strong in intensity, duration, and frequency. This persists till the cervix dilates to about 4 centimeters when the active phase is reached. The active phase is more steeper in the sense that the cervix dilates more rapidly, about 1 centimeter in a primi and 1 to 1.5 centimeters in a multi. So in this phase, there is a rapid dilatation of the cervix, and this continues till it's 10 centimeter dilated, and when it's fully dilated, the curve becomes a plateau. That is the second stage of labor, when cervical dilatation is complete, but descent of the fetal head through the narrowest portion of the pelvis takes place. So it is with this curve that we started understanding what labor is. Labor is thus a culmination of complex and complementary processes which are interdependent on each other. The processes may be of 3 types, that is the hormonal, the biochemical, and mechanical factors. So it is these 3 factors which act interdependently with each other to cause the labor. There are said to be 4 phases in parturition: the quiescent phase, the activation phase or the get ready phase, the stimulation phase, and the involution phase. So what happens in the quiescent phase? There is a functional withdrawal of progesterone and other uterine relaxants. There is a mechanical stretching of the uterine myometrium as well as the cervix. There is activation of the inflammatory cascade, which is also needed. The quiescent phase, the hormones which are responsible for keeping the uterus quiet. As we all know, progesterone, it is a progestational hormone. This hormone, along with the relaxin and prostacyclin, is very important to maintain the quiescent phase. They not only make the myometrium acontractile, but they also increase the blood flow to the uterus so that the needs of the baby are taken care of, the gas and the nutrient exchange can take place, and at the same time, a reserve is built up in the uterus so that it can withstand the tremendous energy needs of labor. The activation phase starts when the contractions start. There is, and how do the contractions start? Because of a functional progesterone withdrawal. So progesterone during pregnancy, especially in the late phases, is produced by the placenta in huge amounts, and it keeps up the uterine quiescence, as we all know. And towards the onset of labor, there is a functional withdrawal in its action. So if the progesterone's function comes down, the EP ratio, that is the estrogen is to progesterone ratio, is altered and estrogen takes an upper hand. Oxytocin receptors are formed rapidly and cervical changes take place. There is this involution phase when again oxytocin and inflammatory mediators come into action, which help the uterus to contract and return back gradually to its original non-pregnant state. So let us look into the three important mechanisms which are responsible for the onset of labor. The first comes the hormonal control of labor. Hormonal control is due to the following hormones that we have shown, and each of these hormones have a very important role in the hormonal control of labor. CRH or corticotropin releasing hormone is a peptide hormone which is secreted both by the pituitary hypothalamus as well as the placenta. And CRH increases exponentially just prior to the onset of labor. This exponential increase in CRH will help in the lung maturity of the fetus by increasing the production of surfactant protein A and B. Surfactant protein A and B, when they are formed in large amount, will seep into the amniotic cavity, where they will increase the inflammatory response to again increase the labor pains. And estradiol production is also increased by the placenta due to the SPA and B. The next comes the prostaglandins. Prostaglandins are very important in cervical ripening as well as uterine contractions. The prostaglandins that are important are the PGF2 alpha and E2. Next comes the progesterone. As we all said, progesterone is a progestational hormone which keeps the uterus quiet. And towards term, there is a functional withdrawal of progesterone. And this functional withdrawal of progesterone is due to the alteration of the ratio in the progesterone receptor A is to B. During the quiescence period, A is to B is 1:1. And during the onset, the activation phase of labor, the progesterone A becomes more, and the unliganded progesterone A is responsible for the various actions. The CAP proteins or the contraction-associated proteins are increased, whereas the acontractile ZB1 proteins are suppressed. There is an progesterone-mediated suppression of estradiol during the quiescent phase, and this suppression is removed at term. So estradiol starts acting. It is produced in the placenta, enters the decidua, and stimulates the inflammatory mediators. The gap junctions are increased. What are gap junctions? These are the connection between the individual myocytes. The individual myocytes are connected to one another by the gap junctions, which help in forming a 3D syncytium, where the uterine contractions can be propelled from the fundus down to the body and onto the cervix. So gap junction formation also increases because of progesterone's withdrawal. Estradiol, as you know, enhances the immune cell infiltration and
Madam, we got 2 more minutes, ma'am, because it's 12 minutes time, that is.
okay, enhances immune cell infiltration and oxytocin receptor expression. Oxytocin is the hormone to initiate labor. Action depends on the presence of oxytocin receptors. The oxytocin receptors are highest at the fundus, lower in the lower uterine segment, and lowest in the cervix. These receptors are formed in huge numbers only towards the onset of labor in order to propagate the contractions. And oxytocin also causes a synchronized myometrial contraction with periodic relaxation in labor. Relaxin, as the name suggests, relaxes the myometrium. and in late pregnancy, assists in the cervical tissue remodeling in preparation for labor. The immune response of labor is also important because the physiological state of inflammation is needed to initiate a contraction. There is outpouring of the cytokines and chemokines from the fetal membrane and the uterine tissue, which are responsible for augmenting the contraction. There is leukocyte infiltration into the myometrium, and all the cytokines and chemokines enumerated are produced in huge quantities to initiate contraction. This inflammation does not stop with the labor, but also continues postpartum to help in remodeling. Let's go into the mechanical effects. The mechanical effects on the cervix occur in the non-pregnant state and also in early pregnancy. The cervix has the collagen fibers, which are maximum, and the collagen fibers are arranged in the form of helix with cross linkages between the fibers. What happens at term prior to labor is that these cross linkages are broken down and the collagen fibers become wavy instead of straight helixes. And not only that, there is influx of water due to the hyaluronic acid secretion, and there is derangement in the collagen fibrils due to infiltration of the immune cells. And all this makes your cervix soft and ripe prior to labor, so that when the contractions start occurring, the ripe cervix can stretch and dilate more and more so that it can be pulled over the fetal head, just like your socks is pulled over one's feet.
Madam, I'm sorry to interrupt. 3 minutes extra given, ma'am. I think you need to conclude, madam.
Yeah. So the uterine contraction, we all know, occurs because of the, I'm finishing with this, ma'am. This is the last.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you.
The calcium, because the calcium enters the cell and forms the calcium calmodulin complex, which acts on the myosin light chain kinase, and this will ensure that actin and myosin join together to form actomyosin, which causes a contraction. And as the contractions become stronger, more frequent in intensity and duration, labor progresses, and finally, we end up with the birth of the baby, which should be a happy news both for the mother as well as the obstetrician. Thank you.
Thank you so much for the nice and elaborate talk. Dr. Charmila, would you like to say something?
No, we'll go on to the next talk. Madam, any questions in the chat box, please answer, madam. And please join us around 7 o'clock, ma'am, so that any questions you can answer. Thank you so much. Thank you.
So now we move on to our next speaker, that is Dr. Poonam Verma Shivkumar. She is Director and Professor of OBGY and Medical Superintendent at Kasturba Hospital and Mahatma Gandhi Institute of Medical Sciences, Sevagram. So Dr. Poonam ma'am, please you can proceed. She'll be speaking on interventions in latent phase of labor.
Yes, a very good evening to all the faculty here. I'll just share my screen. First of all, thank you all the organizers to invite us. Is my screen visible?
Yes.
Yes, ma'am. It's visible.
Slide show.
Yeah. Is it moving, madam? Okay.
Yes, moving.
So a very good evening to all of you. Today, what we are going to deliberate is on a very important topic, which is interventions in latent labor. Now, whenever we come to this topic, there are two interesting things. Whenever you do these interventions, which are recommended now, they actually stop the interventions which are unnecessarily done in latent phase. So those two things we are going to cover today. I again bring greeting from Mahatma Gandhi Institute of Medical Sciences. We are very strictly following now natural birthing. and midwifery initiative in India. My session objective for today's session are understanding what is latent phase and what are its variation. What are the usual interventions which we do? What is the purpose of evidence-based interventions? And then what are various evidence-based interventions? So whenever we talk about latent phase, we are talking about latent phase which extends from the initiation of labor to the onset of active phase. So that's a very beginning part of first stage of labor. The latent phase generally begins with a long firm cervix that is closed, and then there are some irregular contraction where the cervix starts softening. It dilates 4 centimeter and then it is accompanied by regular contraction. Now, during this phase, as Madam has already said, the cervix undergoes a process of rapid remodeling, and then this becomes gradually a week before or maybe a few weeks before the dilatation starts. As a consequence of extensive changes in the collagen and ground substance, the cervix softens, becomes thinner, and then it becomes prepared or compliant to dilate in the active phase much better. Now, all these changes which prepare cervix, they certainly dilate the cervix much easier in active phase. Why? Because the cervix length reduces significantly, what we say effacement. Coming on to how long is your latent phase, this has been a major query now. The normal limits in our reference book still says 14 hours for multipara and 20 hours for nullipara. But there have been several modifications, and looking into the era we are where the women would not really like to wait for these many hours in some or the other variety of pain. So there was a modified WHO patograph by WHO where they said that 8 hours should be the latent phase beyond which we should intervene. But there are a lot of queries and questions regarding this state. So the latent phase usually is the longest and least intense phase of labor. But again, the question is, it is not precise. There is no identifiable hours. Duration is not fixed and so on. So it can be only estimated. Now, if we look into this figure, consistently we moved from 3 centimeter in the original patograph, the Friedman's curve. Then we go on to modified patograph where they said that 4 centimeter. Till 4 centimeter, it is latent phase. And then in the labor care guide, now we say it is 5 centimeter. So friends, why are we moving like this? Why there is no consensus? Why diameters are being increased? So there are some issues which we need to understand. One is that there's too much apprehension of laboring women during this latent phase because there's small amount of pain which is continuing for hours together and the patient really gets sick of it. There's a lot of fear factor, and this fear factor is that if the pain is lasting so long, then will I deliver normally or not? Will my cesarean be done? Who will do my cesarean? Will I come out of it? And so on. Pain is so intolerable because she has not yet gone into the active phase and experienced the pain, but there's a small kind of pain, brings maternal distress. There's also a huge issue to identify whether it is a false labor or it is a latent phase. So again, there's an issue. Cesarean sections are being done outrightly. I would say whether medical college or any private facility or many other places in the government facility, you will see that cesareans are wrongly labeled, stating that this is a prolonged latent phase. And present era where no laboring women tolerates this much hours, she wants to be delivered very fast. And many a times it is our distress because we are seeing the women lying down 18 hours, 20 hours, and then we think that no, she needs cesarean section now. So it is, of course, obstetrician distress as well. Now, what are the factors that have been associated with the prolonged latent phase? Deficient pre-labor and intrapartum cervical remodeling due to collagen issues, high assimilation pelvis, apprehensions and fear. This again, there's a very beautiful article stating that if we are too much tensed, apprehensive, the spinal cannot be given, the effect of a spinal does not come, effect of epidural does not come, the cervix is resistant. So that is there. Maternal obesity is also one of the reasons where, it has been seen that the latent phase is normally prolonged. Early rupture of membrane again is a reason for prolonged latent phase. Chorioamnionitis, again the infection and the membrane rupture. Then excessive maternal analgesia and anesthesia, so epidurals and all which are given pharmacological methods. There again, there is prolonged latent phase. And approximately 10% of women with prolonged latent phase are actually false labor and their contractions eventually abate spontaneous. So what are the general interventions we do in the latent phase? So two important things we all know. One is augmenting uterine activity with oxytocin or prostaglandin, or giving some kind of sedative to understand whether it is truly a latent phase or it was a false labor. Both are equally effective in advancing the labor to active phase. A very long latent phase may be harboring some or the other kind of abnormal uterine dysfunction, and so it is of very great importance that we have to know whether this is truly a latent phase or not. Now, if we go into AJOG, we will see that this has been a chart which has been given since time immemorial, that you have to wait for these many hours and then you have to justify whether truly it is a latent phase. And then if it is a latent phase which has gone beyond 14 hours, 20 hours, then you augment the late. But there is lot of recommendation now, and there are a lot of various methods by which we can help the women in this particular phase. So what is the purpose of recommending these evidence-based intervention in the latent phase? So one is to allay her anxiety and help her for better dilatation, to distract her so that what happens is that the hormone, which is pro-dilatation, endorphin, is secreted, to educate her to understand difference between false labor and latent phase, certainly to reduce her pain and her pain triggers, to avoid unnecessarily pharmacological interventions, so intervening to stop pharmacological intervention, and to prevent unnecessary cesarean section. So coming on to these evidence-based recommendations, very quickly, I would say the first and most important is counseling and consent and providing her respectful labor care. And if we see 2019, there's a very beautiful article of Boyer, which says that if you would give her education, counseling, support, hydration, position changes, and non-pharmacological methods, you will certainly see that her cervix will dilate very easily, her birthing experience will certainly change. So this becomes the need of the hour, and these are the rights which probably are the women's right during labor, and we all have to ensure that we provide her this. Second very important recommendation is that please let her be Swayam. Her choice, her dignity, her privacy. So ensure that she decides where she wants to deliver, with whom she wants to deliver, who will be with her. And if we provide all these things, her certain hormones which are troublemaker are not secreted, endorphins take over, and then she delivers much faster. And her latent phase is reduced. So these are her universal right again, and we have to provide her to remain Swayam. Another very important recommendation in latent phase, which can really change the latent phase, is providing 100% birth companion of her choice. But here, birth companion should have some roles and responsibility, and she's not there only to play mobile and sit and do nothing. They have to be counseled in LDR. They have to create awareness. We have to create awareness on what they are supposed to do and what is desirable. And we have to take their signature for accountability. And this is what we have been doing. We have made these things very important for the birth companion. So 3-4 women come together, we counsel them, tell them what are their responsibilities, and this significantly reduces the workload on the nurses and provides the best results, especially in latent phase, to the particular women. And these are the literature which clearly says that if you have the birth companion of her choice, her delivery is much faster. Latent phase goes into the active phase. Now, second very important thing, which probably is today's main crux, non-pharmacological method of pain relief during latent phase, and ball uses, bar uses, peanut ball use, hydrotherapy, aromatherapy, hot and cold fomentation, special breathing exercises, acupressure, massage, yoga and exercises, and beyond that, giving her a calm environment where there are no pain triggers. And these props are used very clearly. We would just like to show you that this has been used at our place and results have been phenomenal. And if you see this particular aromatherapy at our place, lavender is the one which is being used, and we're doing a study, 60 patients we have already done, and this certainly dilates the cervix much earlier. So there have been also a meta-analysis where, it has been recommended that aromatherapy changes all 3 stages of labor very quickly. So these are ball, ball, and you see there's a particular way of using these balls. So this is something which is very, very important. Hormone, as I said, that these are 2 hormones which are very painful, catecholamines and glucocorticoids. So endorphin is the one which we have to use for reducing the pain. And these are various non-pharmacological methods which are providing increase in endorphins, and therefore they take over the pain which is there during this period. And these are the pain triggers which could be direct or indirect, and we have to ensure that we avoid all these things so that the pain triggers are not there and the women is comfortable in latent phase as well. Another very important thing is that while we are doing these non-pharmacological methods, there are 2 terms. One is called counter nutation and nutation. When you roll on the ball, when you sit on the bean bag, when you take aromatherapy, bend and take aromatherapy, there is something called counter nutation, where there's posterior tilt of sacrum and your inlet increases. And there is something called nutation, where outlet increases, where there's anterior tilt of sacrum. These are also very, very helpful in dilating the cervix, pushing the head down, and reducing the latent phase. Beyond that, there are some supportive therapy which are expected by the birth companion, or if they want, they can have a big role of doulas, who are nowadays there in India, but now the concept has come and Fernandez Hospital is training doulas. So ambulating the women and never letting her lying down, giving nutrition to the women where you give IV, where you give oral fluids, oral fluids, and then support her during pain. So these supportive therapies by doula or the birth companion probably also help. And this is a very interesting thing, is that Healthline has mentioned what you are supposed to tell the women while she is in the latent phase. And these are the things which you have to tell: how she'll keep her busy, keep moving, take warm bath, stay hydrated, eat what foods are required to be eaten, and then, of course, breathe in such a way which helps her during or which helps her in dilating the cervix. And then, of course, the patography, only patography, which is talking about monitoring the latent stage and reducing cesarean section, is ARC patography. We strongly recommend it at every platform. And if you will see this, this is going to reduce your cesarean sections, which are done unnecessarily during latent phase. And then last but not the least, please add midwifery cadre, because they provide RMC in true sense. They monitor latent phase very particularly by using various props. Alternate birthing, they help, and the women comes out with the excellent birthing experience. And this is where how we have changed our scenario, where cesarean sections have reduced, labor outcomes have become much better, and ICU admissions have reduced. Normal deliveries are happening without episiotomy. Perineal tears are there, but not like episiotomy. And this is where the birth companion has various roles and responsibilities at our place. Sorry. Yeah. Yeah. So coming on to the end, this is how we are delivering the women in different position. Almost 40 to 50% deliveries are in various alternate birthing position. So you have hydro labor, you have with this thing. So finally, coming to the end, my take-home message would be latent phase is not well defined and it varies. Differentiate it from the false labor pain. Use all non-pharmacological method of pain relief and you will see how it reduces significantly. Please avoid unnecessarily interventions like, giving epidocin, buscopan, oxytocin, prostaglandins when actually she doesn't need it. Provide respectful labor care, birth companion, use props, give midwifery care, and this is all going to change your latent phase certainly. And prevent unnecessarily cesarean section by plotting arc patography in latent phase. Thank you very much for your patience here.
Thank you, Dr. Poonam. That was a wonderful talk, I would say, explaining everything that over-enthusiastic obstetrician should not be there. And Dr. Charmila, would you like to add or should we be moving to next?
We'll move ahead. Poonam, madam, there are some questions in the chat box. Please answer them, ma'am. They're asking regarding the patography and all that. Thank you, ma'am.
Arc patography is something which is called advanced real-time patography.
Madam, please answer it in the chat box, madam. We are continuing.
Okay.
Thank you so much, ma'am, for joining today.
Thank you.
We'll call you for a master class again. We'll call you for a master class again.
Yeah, sure.
So now I call upon Dr. Jam Kanan, ma'am. She is Emeritus Professor, Tamil Nadu MGR Medical University, a brilliant teacher, I would say. You are lucky to have her here. So ma'am will be speaking on interventions in arrested labor. Her experience is tremendous. So welcome, ma'am.
Am I seen and audible?
Yes, ma'am.
Yes,
Clear.
So interventions in arrested labor. For a change from physiology to latent lift, let's just get into the problems. That is why I have been put here in between two nice topics. Okay. The interventions in labor. Arrested labor 2024 American College has come out with a lot of references. That is why I have been diamond and putting 2.5 million delivery people are giving advices for 25 million delivery people. That is what I said. Oxytocin administration, which was questioned in 2020 by Europeans, have been little changed. Amniotomy is taken up. Intrauterine pressure catheter when and where there is possible. Ultrasonic imagination assess the fetal descent. Why it is important, it will come as a course to the directed. Shared decision making as Poonam was talking about, operative vaginal delivery or cesarean delivery. Even at the last moment when you are into the theater, please try to do a operative vaginal delivery in the operation room. What is arrest? What is descent? There are two important terms. Arrest is lack of dilatation for 4 hours despite good contraction. Lack of dilatation for 6 hours with inadequate contractions. Or there is a complete pause in the labor progress. All these things are arrest. What is descent arrest? Head of the fetus in the same position. You have done a PV at 10 o'clock, again doing at 11 o'clock or 11:30, same position is what is called arrest of descent. First stage arrest, second stage arrest is the one. Third stage arrest is also one which everybody knows about the details. So first stage arrest, as with the ACOG, 6 centimeter plus up to full dilatation, 5 centimeter if somebody is following WHO. Or 4 hours after a good contraction of 200 Montevideo units. Or 6 hours or more of inadequate contraction with no cervical change as has been defined by Medscape in 2022. Now, I put a case. She's a 32 years primary, college going professor. She had normal height weight, normal baby, 9 hours of first stage of labor, ruptured membranes at 8 centimeters, clear like also. We made everything nice. Head is seen. 2 hours part. Head did not come down. The exit sign was not there. baby was maintained. How I could have managed this patient is what I am going to say to you in this one. If I have given oxytocin in this primary, as per the ACOG 2024, 75% will deliver within 2 hours. 90% in 2 hours multi. If I have waited for next 4 hours, ACOG says very clearly, you still have 88% multi-delivering, 56% of the primaries delivering even after 4 hours. This is where the present labor care guide has come, where it is satisfying all the other details of a progressive good labor even in the first stage of labor. Now, as Poonam said, pain management in the first stage, whether it is prolonged or normal, is required. Epidural is concepted with strong recommendation. Amniotomy in the first stage arrest is also being recommended as it has shown to increase the spontaneous labor and a little earlier also. Kindly note, none of the trials have shown a cord prolapse in rupture of membranes in the first stage of labor. Rather early amniotomy shortens the delivery time also. Second is oxytocin, low dose, high dose. All people have got the question of what dose I give. It depends on what has been your regular experience, whether you give a low dose or high dose, because both give the same report. There's no difference, but both of them say that they increase the spontaneous vaginal delivery and go for less cesarean date. Look at this data which I have taken, both low dose and high dose, as it has been done in 2022, it gives the same thing. So low dose or high dose has not been shown to have any statistical difference. So both of them can be used as per your convenience, as per your protocol, and as per your experience. As Poonam said, all this method which she has talked, I am not going to say. Yes, all these things can support you in the first stage of labor also. Propranolol or any of these relaxants are not recommended by ACOG or by any other thing. Can we predict the second? Now we have finished the first stage. In that patient, what I had done, I have increased the dose of oxytocin. I waited for another 1.5 hours and I applied a vacuum, had a baby, and that baby is quite all right and she is a PhD now. Now, after the first stage, second stage, before I go into the arrest, can I predict the second stage is the question. You can identify it if the fetus is not rotated and there is no descent. That is why arrest of descent becomes a very important thing, and that is a good practice point as per RCOG. Epidurals, when you have given 3 hours, longer than 3 hours, it has been shown very clearly, if you increase by next 1 hour, you reduce the cesarean by 50%. So it requires, of course, a shared decision with the patient as an intervention for arrest of labor, second stage. Now I have the second patient, Gravida 3, 2 full-term normal deliveries, presently at second stage for more than 2 hours. CTG source 120 to 140 Montevideo units only. Average baby, mid-cavity state. What I should do? Now I go through my work. Can I rotate it manually, which is being talked so much in America? It is recommended, but it is not practically done, as it requires a small baby, a good roomy pelvis, a good adequate liquor, and the obstetrician should have a hand, left hand, which can go and change the baby very clearly. If it is this thing or right-sided arrest, or if it is a left-side one, you have to do like. Unless we have been efficiently practicing that, it becomes difficult. Cesarean section, I'm not going to expand as there have been many speakers on this, but it is a good, strong recommendation for active arrest of labor, both in the first stage and in the second stage also. But in the second stage, kindly note, after going into the theatre also, kindly try to do a vaginal delivery, which Dr. Charmila knows well that we have done it about 2 months ago in her hospital, and it gave a good success also. So even in the theatre, while you are preparing the patient, conditional recommendation, not a good quality, but still can be accepted in good practice hands. Now, data on assisted vaginal birth, know very well we are going down with vacuum. We are almost getting flattened with forceps, not to speak about Odon, which is now coming up. Now, with all these things which I have said, you know very well you require experienced, expertise obstetricians for managing arrest of labor. Those who have passed after 2000, Y2K, we have 25 years have passed, 50% do not feel competent about assisted vaginal birth. 90% says that they may do a vacuum if there is another colleague by their side. 100% ready to do a cesarean section only. 1%, maybe 1.9% want to do a forceps. Experienced obstetrician competent at mid-pelvic birth is a must. I am not saying it. Journal of Perinatology has looked at its neonatal injuries regarding the competence of the surgeon, and this is a report given by them. Now, we all know well the outcomes are of the assisted vaginal birth means either it is a forceps or a vacuum. In the forceps, it can be a long axis traction forceps or the Wrigley's forceps. I am very lucky to still hold an axis traction forceps, which is not available. Very thin one, which I can use very nicely. Many of you are having this only. International Journal of Nurses Studies has given very good details about this paper. Forceps means a full dilatation, proper application at this level is all this thing. For you, if you are doing a mid-cavity rotational birth, it is better you do it in the maternity operating room. If you have got an outlet, ingoing forceps and outcoming head, it is okay. But if you have mid-cavity, please do it at the operating room. Green Top Guidelines 26 have made a lot of things on assisted vaginal birth, and it talked about forceps to be done only by an experienced obstetrician, but it also makes very clear that fetal head position should be noted, ultrasound assessment of the fetal head position. How many of us are having the ultrasound facilities and expert and trained to measure the angle? So now it becomes out of question for us to apply a forceps as per Green Top Guidelines. That is why many are not doing it. So intrapartum assisted vaginal delivery, ultrasonogram, somebody is talking, I am not going into the details. Vacuum, of course, we know very well it is very useful. But only when the vacuum is not, this thing, when you apply it, wherever you get into the baby's head, you cannot apply. If you go as much posterior, you should be able to have a descent, flexion, and pull down and pull up, you will be able to get the baby very nicely. And it preferably baby should be in the low position with less than a small cavity, caput, and patient should have good contraction. These three are the criteria for anybody to have vacuum application. Vacuums are better to be autoclavable, variable sizes, any vacuum component to be attached, and it should be same. Many of I see with a kiwi. These are the days where the longer the days when I use this thing. Then I started using this thing. Even now, I would prefer this one rather than this one. Because when you go near the maternal side, the this thing, comfort given by this one and this one is much better than this kiwi and this one. So the slipping is very much possible. More than 2 pulse failure is not good. And for you, you should have a proper equipment so that you don't fail. Vacuum extraction versus forceps in the 21st century American College has made it very clear. With a single equipment, forceps is more likely to deliver. But maternal trauma are more with forceps. Cochrane 2021 has made it very clear that there is no difference in the neonatal outcome with forceps or vacuum. But in the vacuum, if you are using a rigid cup, you have more injury than the silicone cup. Odon device is the one which is coming up now. I am really, this thing, if I have been a little younger, I would have started this as a trial itself. It's a low-cost instrument, just $50, and it can be applied by anybody with proper training only. It doesn't harm the baby. This thing, you apply it in a baby,
You got 2 more
you
minutes,
start
madam.
pulling it out. Then you start, the cup is taken away from the baby's head, and the baby's this thing goes nicely into this area, holds the head very nicely. You see the head is totally being pulled up. That means Odon is not putting pressure on the baby, and it should be coming out very nicely. And the latest study has shown 88% success. So views on litigation and other things ought to be taken in mind. Record keeping should be fine. So the team to conduct this delivery should be an efficient team, experienced team, and with expertise to team. Thank you. Did I include anything? Did I not include anything? APC item. I don't feel that a baby which has come out of this and that is +2 position is an arrest. Nowhere ACOG also mentions about it. So care in low resource setting nowadays is too little and too late. Whereas in the fastest growing urban areas like Chennai, Bombay, Delhi, it is too much and too soon we are doing it. We should have a via media with people like Poonam, they sing Goyal and Poonam, they sing from Gramdan Institute and other places with VP Paley, who is there in Kerala, with all other expertise, giving a good details about the present trend in management of deliveries. Somebody was asking me, even yesterday night, I had a prolonged labor wherein the arrest was there for about 2 hours. We delivered the fetus. Of course, baby did not cry at birth. It cried after 30 seconds. Thank you very much for your patient hearing. Over to the organizers. I am stop sharing.
Thank you so much, Dr. Jam. That was very wonderful talk. And Dr. Charmila, if you want to add, or should we be moving to our next session?
We'll
I
move on to the
think we
next
are
session. There are
exact
some,
on time.
yeah.
We
There
are
are,
exact on time.
there
So
are some
now I
questions.
invite
No,
my.
there are some questions for Jayam madam. You can answer it in the chat box.
Yes, ma'am. They are asking for some form which
The
you fill
consent
before
form and all
the-
that they're asking,
Yes,
madam.
yes,
Please
yes.
answer it.
I have put a form there. I think that form they can download it from your presentation, which has been put up by the RCOG.
Okay.
RCOG has given it in the assisted vaginal birth. This form very clearly.
Yeah. Madam, please answer in the chat box, madam. There are
Okay,
some more questions also.
I will answer this.
So now I invite my co-host, Dr. Ummeyal. She is Managing Director of Shri Kumar Specialty Hospital, and she will be conducting the session 2. Dr. Ummeyal, are you there? Okay.
Yes, I'm very much. And now coming to the session 2, after a very wonderful session 1 conducted by 3 stalwarts. Jay Madam's speech was very, very good. Now the second session is all about the recent advances in labor, what's happening. We have AI in labor prediction, Omics in labor prediction, maternal positions in labor, and programmed labor. So all these are new words, and we have got more than 550 delegates listening to it. And we have got 2 wonderful chairpersons to conduct this session. The first chairperson is Dr. Asha Rao, and she is the chairperson Endometriosis Committee 2022 to 2023, Director of Rao Hospital. Madam, welcome, madam, to chair the session. The next chairperson is Dr. Singh, Professor and Head of Department, the Medical College. Asha Rao, madam, are you there?
Yeah, I'm
madam
here.
is
I'm
there,
very much here. Good evening.
Yeah, please,
Good evening, everybody.
please stay.
I congratulate at the outset Dr. Charmila and Poonam for having managed such a beautiful program. And it was a wonderful lecture by Dr. Jayam. And now we have brilliant Dr. Kaundina Desiraju, who is a reviewer for Association for the Advancement of Artificial Intelligence. And he has got very special research interest in building and validating translational models using AI for healthcare. And he'll be speaking to us on the use of AI in labor. Dr. Desiraju, please.
Hello, hi everyone. Am I audible?
Yeah, you're
Yes.
audible, sir.
Yes, we can. Yeah.
Thank you, thank you. First of all, let me thank all of you and Dr. Sharmila especially for inviting me and having me here. So this session would be, I think, a little bit different. I am not talking about practice guidelines and all. You guys are all the best obstetricians and gynecologists in the country. And as far as myself is concerned, I did my MBBS, and after my MBBS, I have pursued research route. I have done my PhD and in data science and artificial intelligence. And after PhD, I got the fellowship of DBT Wellcome Trust India Alliance Fellowship. As part of that fellowship, I am working with Garbhini team and I'm representing Garbini team from THSTI, and my colleague Pallavi Kshetrapal is also there to speak on omics labor prediction, who will be speaking after me. So we both are representing Garbini team here, and thank you once again for inviting us. I'll first speak on applications of artificial intelligence in obstetric ultrasonography. I hope my screen is visible to everyone.
Yeah, yes, sir. It's visible. Yeah.
So let me start with giving some outline about the Garbini cohort. So we 2015 to see the look for the pathophysiology of preterm birth. There are no cohorts which are longitudinal, which are well phenotyped in the country and across India. So Professor Bhattnagar and team started this cohort in 2015. We call it Garbini cohort. Here, as you can see, it's a longitudinal cohort. Our final sample size is 12,000 pregnant women. We are enrolling these women in Gurugram Civil Hospital in Gurgaon. So you can see here the enrollment is within 20 weeks of gestation. The earlier, the better. So some people are enrolled at less than 11 to 14 weeks. Some are enrolled at 14 to 18 weeks or 18 to 20 weeks. For people who enroll at less than 14 weeks, we do a dating ultrasound scan. And then again, they'll be scanned at 11 to 14 and then anomaly scan at 18 to 20. And the last three scans listed here 26 to 28, 30 to 32, 35 to 37 will be done. We'll follow up them at delivery as well as postpartum. These are all the visits. And you can see at every visit, we are collecting clinical and epidemiological data, obstetric history, and everything. We have more than 1,000 clinical variables documented by trained study nurses and data collection team. We also have a very good quality control team where double entry of the data is being done, the queries are being raised and resolved, and we follow the proper protocols, almost similar to clinical trials quality we maintain, even though it is a cohort. And a lot of biospecimens, as you can see, were being collected at enrollment during the follow-up visits as well as at delivery. On the right, you can see the kind of data that we are correcting, the social, demographic, environmental, obstetric complications, everything I have mentioned. And the biosamples include maternal sera, plasma, saliva, urine, high vaginal swabs, neonatal heel pricks, and cord blood at the delivery time point. Even placental punches and placental tissue we are collecting, including paternal saliva as well. Dr. Pallavi will speak more on the biospecimens, biosamples on the wonderful biorepository we have. It is now one of the nation's biggest biorepository. And in the same repository, we also have the ultrasonographic images as well as videos collected from all these ultrasound scans. So this is the overview of Garbini cohort. Now I'll just jump into the AI bit. As I told you, over 1,000 clinical variables, 600 ultrasound scan variables, and uh, 76 biological samples allocated into so many aliquots. As per ultrasound images are concerned, we have 7 lakh ultrasound images collected till now and 30,000 videos as well. So if I can give you the overview of the plan, how we are going to incorporate, what is our vision in incorporating AI in antenatal ultrasound. So imagine one patient walks in and a sonographer there has taken the images as per standard planes, everything. And our model, if you just open the software, in the software, if you just open the folder, the first model we can encounter is we call Luyu classification model. It identifies the anatomies. It identifies whether it is of abdomen image, the image is of femur, head, placenta, or cervix, etc. And then after identifying, we have models for estimating fetal biometry automatedly, gestational age, as well as for prediction of preterm birth, small for gestational age, and other adverse outcomes. So here everything is automated, so it saves a lot of time for the sonographer, they need not fit ellipse manually and identify biparietal diameter, draw a line, measure all these things. At the same time, it also reduces the chances of intra-observer variability, etc. In fact, now I am focusing my talk around gestational age. As you all know, gestational age is the cornerstone of the you know clinical care. Everything revolves around, we at 26 to 28 weeks, we screen for preeclampsia, we screen for GDM, everything revolves around gestational age. Even the onset of labor and the decision on whether to go for a clinical, cesarean surgery or whether to deliver that woman, now wait for a couple of more weeks, everything revolves around the accurate gestational age. So in order to give accurate gestational age, we follow these three different methods. First is just using fetal measurements. We built regression model for estimating gestational age, just like Hadlock or intergrowth. But as you know, Hadlock, it's been very old formula built in very few Caucasian participants. Intergrowth, even though it has some kind of Indian representation, but it is not true representation. They have a lot of exclusion criteria. So we wanted to build gestational age estimation model for our population and see if it is better than Hadlock or intergrowth. And apart from that, we wanted to use just ultrasound images and see if we can, build accurate gestational age models. I'll briefly describe why we are using images and what are the advantages that comes with it in a later studies. So here, in collaboration with IIT Madras, we have done this exercise wherein we have created our own formula, Garbini 1, as you can see in the top row, and compared it with all other formulas. This was done for first trimester using CRL. So here, as you can see, more or less all the formulas are performing similarly. On the x-axis here, error of these models are plotted. So we have concluded that if we use CRL, less than 14 weeks, doesn't matter which formula you are going to use, we are going to get accurate gestational age, and that has to be considered as gold standard. So we have taken this gestational age measured using CRL in first trimester as gold standard and started to build gestational age estimation models for second and third trimesters of pregnancy. Here it is also very relevant because 40% of our participants come for their first antenatal visit in second or third trimester. They don't have CRL based gestational age estimation, and hence these models become more important and more relevant in our context. Here in Garbhini cohort, as you can see, we have first trimester dating as done by CRL. We take that as a gold standard, and from the ultrasound scans done at 18 to 20 weeks and 30 to 32 weeks, we have taken biometry which was measured, and using that biometry, we have made models for estimating gestational age. Here is one such example. Again, we are comparing our Garbhini GA2 model with intergrowth and Hadlock. We are in process of patenting these models as well as published it in Lancet Regional Health. As you can see, especially here, the median error in weeks, it is in Garbhini cohort, Garbhini model, it is much lesser when compared to intergrowth and Hadlock. And in a similar way, we have validated this in one external cohort, which is from CMC Vellore. Here also you can see the error, especially the median error here, is much lesser when compared to routinely used Hadlock model. So here also you can see the Hadlock model's graph is a bit off compared to Garbhini and intergrowth. Here we conclude that our Garbhini model, Indian population specific model, is more accurate than the other two. Even while classifying preterm birth, if you can see, we are following up the participants in Garbhini till delivery, and we know who have delivered at preterm, who have not. So this gold standard bar is the bar where we have directly observed the proportion of women who have delivered preterm, which is around 10 here in this sample. And while using gestational age from Garbhini GA2, it is the closest, the preterm birth rate came out to be 12, which is closest to the truth. whereas intergrowth and hadlock are overestimating the preterm birth prevalence rates in our population. So for epidemiological studies as well, this model will be more helpful. So jumping the gun towards the ultrasound image-based gestational age estimator, we call it gauge. This gauge model, we thought the hypothesis mainly behind this model is that convolutional neural networks based feature extraction methods. This may extract features beyond biometry and help us build accurate models in second and third trimester. So till now we are relying on biometry. That means that we are saying that the size of the head, the size of the abdomen, the size is related to age. But when fetuses are not growing well, for example, in SGA population, the size is not always equal to age. There, we hypothesize that if we use AI and use raw images, the AI can see little bit of features from inside of the head or from other parts of the image, and maybe might be able to give accurate gestational age even in those people who have SGA or they are not growing well. So here our model, if you give image as the input, it identifies the head like I have shown in the picture as well as give gestational age. So here I skip this in the interest of time. Finally, we have 2000 participants and around 10,000 images to build these models. And you can see our gauge model, the error of the model, which is shown on y-axis, is much narrower when compared to existing hadlock and intergrowth models, where they have much more error. In fact, our model is 44% better, more accurate than hadlock and 35% more accurate than intergrowth. We are also in process of publishing this work as well as patenting this work. And I have received best oral presentation award in ISWOG when I went and presented last time. So to check our hypothesis, we have also tested the accuracy of gauge in and other models in appropriate age for gestation babies, fetuses, as well as small for gestational age fetuses. As you can see, the blue one is appropriate AGA and orange one is SGA. Gauge model is performing similarly in both AGA and SGA, whereas hadlock and intergrowth are underestimating the gestational age in SGA babies. Here the size is, I'll just take a couple of more minutes. Where the size is smaller, as expected, the models are underestimating. So this is, we would say, a remarkable result, and that makes gauge model a better choice in populations where SGA is more prevalent. Example, in India, the SGA is around 35%, so it will be better model for our country. If I can just quickly demonstrate our model, if you see, I click on browse files. I am selecting the image here, image of head. So here, if I say view, the algorithm is running and it automatically says this is the image which belongs to head. And if I click GA, which is gestational age, immediately it calculates the gestational age and it shows, it identifies the head as well as it shows that the gestational age is 18 weeks and 5 days. So this is how our tool works. And quickly to sum it up, we also do, in fact, Dr. Pallavi and her team have done this work where postnatal assessment of gestational age using metabolics from neonatal heel prick sample, where we are measuring amino acids, cartinins, and TSH and other metabolites in neonatal heel prick blood, and use machine learning models to predict gestational age post delivery. As soon as if some participant comes directly for the delivery to the hospital, after delivery, if the baby is small, immediately this method helps us to get accurate gestational age at the time of delivery and facilitates the management in the neonatal ICU. As you can see here, while including only these much predictors, and if you go on to add each and every predictor, the final model is predicting gestational age with just plus or minus 7 days error, which is remarkable as well. So this completes the story of gestational age. Now we want to validate these gestational age models externally in multiple sites across India. As you can see, these are sites spread across India. Here must be another ring at Hyderabad. We are doing at AIMS Delhi, KGMU Lucknow, AIMS Guwahati, and in the west we are with Bharati Vidyapeeth Pune. In central it is Fernandez Hyderabad, as well as in Pondicherry Institute of Medical Sciences PIMS. There also we will enroll 4,000 pregnant women is the sample size and we follow them at different time points till delivery, and we plan to validate these gestational age models in those cohorts. Once validated across the country, then these models will be ready for clinical use. And hope I can answer all of your questions regarding this gestational age, and we definitely welcome your feedback on the utility of these models, and we are looking forward to working with you once these models are validated. Thank you so much.
So Dr. Asha ma'am.
Yes. It was a wonderful lecture, Dr. Desiraju. I think AI is being misused for so many wrong things, and it is wonderful listening how best we can use it for the prediction of labor. And it's fantastic that you are making a study. So much research is ongoing, comparing the data, Indian data, and the Garbhini, whatever, comparing with the head doc. It's very interesting. I'm sure there'll be many more questions coming up in the chat box, which I request you to answer.
All right, definitely. I'll do that.
Poonam?
Thank you, sir. So Dr.
Thank you.
Poonam,
Thank you
next
once again.
speaker, please.
Yeah. Our next speaker, I welcome our next speaker, Dr. Pallavi Kshetrapal. She is the Associate Professor and Faculty in Charge, Biorepository, the Translation in the Health Science and Technology Institute, NCR Biotech Science Cluster at Faridabad, Haryana. Once again, she is another brilliant scientist, and she got the outstanding award in the field of biobanking by the Biobank Foundation of India. And she also got the leadership journey. She got the aspiring leader for the 2024 India Leadership Journey Award by Women Lift Health by Bill and Melinda Gates Foundation. And we're all very eager to listen to her talk on omics in the prevention of, in the prediction of labor.
Thank you very much for
Pallavi,
the
please.
wonderful. Thank you very much for the wonderful introduction, and I hope my slides are all visible.
Yes.
Okay. And first of all, on outset, I will like to thank Dr. Charmila and her complete team here who have invited us from THSTI. Thanks, Condi, for introducing the cohort. That makes my life a little easier. So I'll straight away start that whatever Kaundinya is doing on the AI aspect, we are doing in Garbhini with a huge team. And I'll slowly in my subsequent slides introduce you the omics approaches that we are taking for labor prediction in using the Garbhini cohort as a national resource. So Kaundinya has already explained that we are taking a lot of epidemiological data, socio-demographical data, medical data, and also biospecimens that we are collecting along or across the trimesters, not only at delivery, but also at postpartum, and also the ultrasound data that Kaundinya beautifully has put up with 3 strategies to understand the gestational age and predict labor. This is the Garbhini Biorepository that has been now accredited with an international standard, which is 20387, and has the best practices to store and archive all the samples, which are again digitally archived. And these are different samples that Kaundinya has already talked about, and I'm just showing you the thumbnails for them. So utilizing this main cohort, the principal or the primary objective of Garbhini was to enroll 12,000 mother to have the prevalence of preterm birth. And as Kaundinya has already explained that then we slowly started building different questions into this. And this is what Kaundinya has already talked about is the epidemiology and the clinical risk factor analysis using ultrasound-based predictors. And today, after his talk, I'm going to talk about that how biomarkers can also be identified using different omic approaches, which can be fed into the algorithms that are being built by AI using clinical risk factors to improve the prediction of preterm birth. The 4 arms that we are working with, and this is again, as I mentioned, it's a huge team, and genomics is being done by NIBMG at Kalyani, Calcutta. Microbiome is being held by Dr. Bhaptosh at THSTI. Proteomics is being done by a regional center for biotechnology. Dr. Tushar is leading this effort, and metabolomics I am doing at THSTI with the help of the clinicians on board to understand what are the gaps which we need to fill. So what we understand using the knowledge that we have built in is that there is hardly any kit which is available around the first trimester for early prediction of preterm birth. There are different kits which require either cervical fluid or they require the plasma. And the best kit we understand is the preterm birth kit here, which is very costly, and it works on a serum test which can be imparted to the women at 19 to 20 weeks to understand asymptomatic spontaneous preterm birth. So all of us are developing something which we can fill this gap on the first trimester. This has been the approach that everybody is using. As I told you, RCB, NIBMG, THSTI, all are working on the different omic platforms, and all are using a similar approach, using a discovery, which is the discovery phase cohort, which is the preterm birth and the term birth, which are the cases which are selected from a universe of sample which are homogeneous to each other, apart from the fact that the mothers were delivered preterm in one group, and the study arm, which was the other arm, was the term healthy group. Then we go ahead and have univariate analysis on all the predictors that have been identified, verify them on different targeted platforms, because we use state-of-the-art platforms which would not be available at the clinical setting. So we have to step down using few putative identifiers to verify them on those platforms which could be used in a clinical setting, which is like ELISA or a dipstick test. And then we build machine learning models to predict the sensitivity and the specificity, positive and the negative value. Also have the AUC so that we can validate this model or these panels, you can say, a few predictors for identifying preterm birth or stratifying them. So this is the first omics platform which I'm going to discuss today, which is genomics. And through the whole genome sequencing of 6,211 women from the Garbhini cohort, which was done at NIBMG Calcutta by Dr. Arinda Maite, where the blood was collected, DNA was extracted in a particular manner, and then Infinium gold array chips were used. Why are these kits used? Why are these chips used? Because humans have some single nucleotide polymorphisms which do not cause any disease per se, but they are different and they could be associated with a particular disease. Now, what has been identified using a case control study design, again during the analysis, 66 SNPs have been identified which are associated with preterm birth. So now what is happening, this data was also published in the Lancet, and what now is the next thing that is happening, that out of these 66, which are the best predictors which could predict preterm birth? Now, after the genes have been predicted, you need to identify whether the transcripts, whether the RNA has also been affected or not. So right now, Dr. Arinda Maite is working on whether the transcript, using transcriptomics to identify the microRNA, the rRNA, the tRNA, or the mRNA, which could also be associated with preterm birth. So this is a detail about the genomics. The second high throughput platform that was used was LCMS platform. And mind you, there are LCMS platforms in the clinical setting also where newborn testing is very common. So using the same type of high throughput platform, few proteins have been identified and few metabolites have been identified. Metabolites are small molecules, much smaller than the proteins, and you can straight away make some lab-based assays to predict preterm birth in this case. And again, this study design, as I mentioned, was a nested case control study design in the Garbhini cohort with singleton delivery, spontaneous birth, no comorbidity like preeclampsia or gestational diabetes, such that, and no congenital abnormalities. So using a case control study design, discovery has already happened. We have already verified these putative candidates, and now we are validating these candidates on these high throughput platforms to identify and develop lab-based assays for the proteomic or the metabolomic signatures to risk stratify preterm birth. Now, there's a very interesting thing which I was listening in these lectures today. Mind you, I'm a geneticist and I have no knowledge about birthing, but with such beautiful lectures and how the hormones are related, how the placenta is secreting these hormones and taking care of the latent phase or the lag phase or the active phase. So I got interested and started and initiated this human placental program in the Garbhini cohort. Now, placenta is such a thing that once you get the placenta at the end, you will not be able to predict anything earlier, because the unobtainability of this tissue makes you think whether there's another way of assessing the placenta across gestation. So what we did at THSTI is tried to understand and isolate exosomes from the placenta, which are nothing but footprints of the placenta. So these are small bilipid nanoparticles which are secreted out from the placenta and also secreted from the fetus. So all the organs in our body, mind you, secrete these small nanoparticle based bilipid particles, and they are indeed carrying the proteins and the RNA and the DNA of the origin tissue. So what we used this knowledge was that if something is being secreted from the placenta, why don't we use a placental specific protein and isolate them from the maternal circulation, because they go into the maternal circulation. So we used a protein which is placental alkaline phosphatase, which is very specific to the placenta, and from the 3 trimesters we isolated these exosomes and then enriched them for the placental specific exosomes, and this is how they look, which is using a nano tracking particle analysis, where you see these small molecules which have been identified as PLAP positive or placental specific. And you can also use other methods to characterize them, which is transmission electron microscopy, to understand that indeed they are small particles. They are around 150 nanometer or 50 nanometer. And placental specific alkaline phosphatase, which was used to identify these particles, are not seen in the males. They are very few in the non-pregnant females, but definitely because it's a placental specific, we see that it's huge in the pregnant females. So what we did using this, again, went into a case control study design to understand what is there in these placental specific extracellular vesicles. So if these, and we did a case control, as I told you, nested case control study design using term birth and preterm birth, again having a very tight inclusion criteria, where we isolated these placental specific exosomes, PLAPs we call them, from 14-weeker circulating plasma, which was isolated, 18 to 20, 26 to 28, and delivery. And this was the methodology, as I told you, and we went ahead with proteomics. Now, if you see in these boxes over here, which is labeled as A, B, and C, we see that in the preterm birth, in the A, is the blue line, which gets over before, and the red is the term birth. So you see, these are some proteins which are differentially expressed in the maternal circulation, which are placental in origin. So can we study or monitor the placental development without touching the placenta in the maternal circulation? And this is the answer. That is how you could do it. So major findings of our work were where we have found 63 proteins which are showing immunomodulatory properties. Today we have understood that birthing basically is something where inflammatory markers are also turned on. So whether the placentation has happened properly or not, hypoxic conditions are needed, but at the right time for placentation. So these are things which we have tried to find out, and we are working towards it. So this is my last slide, which I'm going to talk about, where using this national research which Dr. Shinjini Bhatnagar and the clinical team with Gurgaon Hospital and Safdarjung Hospital have built up, where this biorepository is already available. Condi just mentioned we have ultrasound markers, we have a lot of clinical data. What has come out from here is the bioresources which have been developed to utilize these archived samples. Then what I mentioned today was the SNP screening that has already happened, proteometabolic integration. Then we also, something which I didn't touch upon today because of time, the vaginal microbiome, where we have also identified some microbiome which is very much associated, and a dipstick test is something which is being made for these microbiome signatures that have been identified. And this is the whole complete team. I just thought it will be very nice to introduce the complete team here, who were the seniors out here and us here, who have a lot of other people, and especially the study participants, and funding that has been generously given by Department of Biotechnology and BIRAC. So thank you very much, and I hope I was on time.
Yes.
Thank you, Dr. Pallavi. It was a fantastic lecture. It took me into another world. Listening to all these terminologies, the proteomics, metabolomics, placental particles, nanoparticles, and how they can help us to predict preterm labor. It's really a great thought. I'm sure the Garbini cohort becomes popular, and you bring out many more aspects which will help us to predict preterm labor. Thank you for that wonderful lecture. I think we should invite you to FOGSI South Zone in June at Ooty. We'll send you an official invite, and please come.
Yeah, thank you, Asha ma'am. And I think Dr. Charmila will also be needing, as Condi said, to validate these things, and we will need support from your network. And we are most happy to work with you collaboratively. Thank you so much.
Once again, we have Professor Dr. Vidyasagar Bengal, and he's the head of the department from Pravara Institute of Medical Sciences, and he'll be speaking to us on various positions in labor, which is very, very important. Professor Vidyadhar, please.
Hello.
Sir, screen share नहीं हुई.
Just.
Yes, now we can see, sir.
Yeah, good evening, everyone. At the outset, I thank ICOG for inviting me and allowing me to participate and share my experience on this particular topic of maternal birthing positions. I'm working at Pravara Institute of Medical Sciences since last 34 years. It's a deemed university. Hospital is Lakshmanyata certified, and we also have a certification from International Childbirth Initiative. We also work with WRI for safe motherhood and respectful maternity care. Overall, the number of deliveries that are taking place, which I have a special reason to tell you, is around 12,000 deliveries per year. Now I will be speaking mainly on few things: different birthing positions, what are the birthing tools and gadgets that are used while using these different birthing positions, and we must understand what is the maternal and neonatal outcome while we use these birthing positions. And I would like to share my experience of how I have introduced this in this big tertiary care hospital having this much of patient turnover. Let us train our postgraduates, teach them, and transfer this knowledge that you will gain in this particular session. What is this maternal birthing position? It's a delivery position, or also called as a labor position. That is simply a physical posture that pregnant mother may assume during process of childbirth. Historically, if we see, there are a lot of sculptures, paintings, which show that women used to deliver in upright position or other than supine position, gravity assisted positions, and that used to help in faster progress of labor. These are some of the pictures depicting the same. If we give a choice for a woman, and which we are giving now, 50 and more than 50% of the women are opting for non-supine position. Only last 150 years, the women are being told or being asked to deliver in supine position. There are certain anatomical considerations. When a woman squats and abducts her legs, there is compression of the upper part of the symphysis pubis, and ultimately it increases, opens up the lower part, and there is a Dr. Poonam has already said about the nutation and counter nutation phenomena, and that helps in increasing the pelvic capacity by almost 25 to 30%. So this is the anatomical consideration, and WHO also recommends in its guidelines 2018 for positive childbirth experience that women should adopt upright birthing position, or it should be one of her choices when we give them a choice for delivery. But why still, even after knowing that yes, upright birthing position is, I will show you, it's much better than the supine position, we are still not using it because we do not have, it's not in our curriculum. There is lack of knowledge and training to support physiological birth. Lack of adequate space is not there. There's lack of adequate space in the labor room. There are non-availability of birthing tools and so-called prevalent modern delivery practices that are being used in the labor on the labor table. Now, if we want to keep women during labor in upright position, we need to use certain birthing tools. And what are they? They are birth balls, peanut ball, rebozo, which is a long flat garment used to maintain upright position, which I will show you. Comfortable upright birth support called as cub, grab bar, and birthing stools. Dr. Poonam has shown some of them in her slides at her midwifery unit at Sevagram. This is how is the birthing ball, which helps in keeping the woman in upright position. There are different ways how we use it. Figure of 8, hip circle. That's how women are told and given knowledge about how to use this birthing ball that will help in the descent of the presenting part. This is the peanut ball. This is how the peanut ball is being used in labor. This is the rebozo, a rope that keeps a woman in upright position. By the side, you see a chair. This is the rebozo used while using birthing ball, use of cub in labor, grab bar, and squat bar, which is a horizontal bar attached to the lower end of the labor table, which here you will see that a nursing staff there is showing or demonstrating it to the pregnant women during their labor room tour. Squat bar. Our postgraduates are regularly conducting deliveries in upright position. These are some of the pictures. Birthing stools. These are the birthing stools on which women are delivering. We developed some chairs for maintaining the upright position. Different models of chairs are being used. This is a chair with or without hand grip. This is another new model that we have developed is steel cushion chair with grab bar and adjustable sliding footrest. And this is how the woman sits and delivers on that. A good ambulation to maintain upright position is extremely important. That helps in descent of the presenting part, progress of labor, and reducing the C-section rate. We also developed one staircase exercise in the labor room, which promotes descent of the head and shortens labor. Women who are there otherwise in the labor ward are asked to be on the staircase one by one, and then they, till they are not really tired, they can just moving on this stable staircase. This is what the staircase exercise that is being practiced. We are also using a birthing ball for pain relief in labor, maintaining upright position. This is the labor room corridor with a bar attached and multiple birthing balls have been kept, and women are doing birthing exercise during. Utilization of spacious labor room corridor. These are some of the pictures how the women are being asked to be in upright position rather than just lying down on the labor table. We also have water birth facility. Since last 15 months, we have delivered almost more than 250 hydro labors. That also maintains the upright position for the women. Now coming to the topic, that is birthing positions. We classify these birthing positions into two parts, supine position and upright position. Supine, which we are traditionally using, is a lithotomy or maybe dorsal position, semi-recumbent position, lateral position, or all four position. Whereas upright positions, which are more favored, are sitting, kneeling, squatting with aid or without aid, and standing position. Now these supine positions are called non-flexible sacrum positions because the sacrum is directly in contact with the surface of the labor table or to the floor if she is on floor, or upright birthing position where sacrum is flexible as it is not in direct contact. So there is a movement possible, and that is how it is helping in the movement of the sacroiliac joint, what is happening as nutation and counter nutation. So these are the birthing position types and classification. As I said, characteristics of placement are given, exactly how the woman is lying in that. Then origin of horizontal, but even after having this knowledge, why the horizontal position has come and from where it has come. The origin of this horizontal position is almost around 150 to 200 years back, and France became the legislator of horizontal childbirth after the French Revolution War. They opened a lot of hospitals for the women to deliver, as otherwise they were delivering on the streets of Paris and other cities. So women were given the position of, they were asked to be on labor table, and that's how, since it started from there, the women also started getting painful, this back pain and all. That's why they started using morphine. That's how those pharmacological methods came. And since women were not really able to push, the obstetric forceps came for their help. Under the influence of progress, the woman in childbirth has turned from an active participant into a passive patient who is just lying down on the labor table till she is in the end of second stage of labor. Overall, upright birthing positions in general increase the capacity of by 28 to 30%, and there is 54% decreased incidence of fetal heart rate abnormalities. We all know that we are not allowing or we are not encouraging them to be on back during the course of pregnancy, and we are asking them. Similar principle applies if the women are on their back, lying down. There is more reduction in the cardiac output that hampers the placental perfusion. There is also reduction in the duration of second stage of labor. Emergency C-section for whatever reason are also reduced by upright birthing position. It is also said that lower need of epidural if we give them upright birthing position. We are all aware about the curve of Caras and how the anatomy of the physiology of the J shape of the birth canal. If we really look at this, if we understand the curve of Caras, we just see that a woman who is lying down, if we ask her to be in the upright position, the course of labor, definitely with the help of gravity, the descent of the baby is much faster. Coming to different positions now that we are using is a reclining or semi-recumbent position, which was even ancient times it was being used, and there was a tilt of 30 to 45 degrees, and that's why the woman was, that tilt was helping woman to deliver. This position reduced the tension on back muscles and reduced backache. But the drawback is, again, we are not taking advantage of the gravity, and those aspects of gravity still remain with this position. Another position is sideline position, although this is lying down position, but since the sacrum is flexible, this is considered as upright position, and this is how this position also being practiced at our place, and this is how the babies are being delivered in lateral position. I will be a little quick because of the time constraint, and this is how the women are delivering in the lateral position. We have to have patience. We don't pull any baby. We naturally allow the progress of labor to happen. All the stages, that is extension, restitution, everything happens on its own. We are using so-called hands-off technique. The resident is conducting this delivery, and that's how the baby will come out on its own without any perineal trauma. I will just go ahead because of the time constraint, because I have to show you a few more pictures. Hands-on knee delivery. This is in the first picture. You will see that the woman is in all fours, and this is how the baby comes out. In all these positions are being practiced. Hands-on knee position, and this is one of the short video. I will just make it fast forward because of the time constraint. Then delivery in kneeling position. She's with the help of a birthing ball, she is getting delivered. With the labor, there is the birth companion is there. So this is how it's all for, with the help of this aid of this birthing ball, women deliver. Squatting position, it also increases the pelvic cavity and almost 20 to 30% increase in the size. These deliveries are being conducted routinely in a squatting position with the help of that squat bar. There are some of the other pictures. It has many advantages. It reduces the need for forceps or vacuums, reduces the need for episiotomy, shortens the depth of the birth canal, and gravity does help. So this is one of the woman. There are two. One is the nursing staff and another is labor companion who is assisting this, and the baby is getting delivered in the, with her own efforts. Then she will lie down and we will practice all the essential newborn care practices are being there. Delivery in squatting position, holding a squat bar. She is holding that squat bar. She is in squatting position. Birthing on chair. These are the birthing chairs that we have developed. Residents are conducting deliveries on the birthing chair routinely. Chair with a grab bar. Second stage of labor is being conducted. Intrapartum fetal monitor. There were questions previously. We conducted almost 20 workshops in all over India in different places. Intrapartum monitoring, there were questions, and it is very easy and possible for monitoring the fetal heart rate with the help of Doppler. Early initiation of breastfeeding taking place on the birthing chair. Breastfeeding in comfortable position. Third stage of labor being conducted. Baby is already with the mother. Third stage of labor being conducted. And this is she's on the table. Birthing chair, delivery. We have to be patient, not to pull the baby. So this is a birthing chair delivery. So last 3 years we have conducted, and then also hydro labor facility. I'm not showing video because of the lack of time, but hydro labor where the woman is in maybe reclining position, if not sitting, but we are conducting it in a reclining position with baby immediately given to the mother after the delivery. And BP and fetal heart rate monitoring is not at all a problem with the hydro delivery. There have not been any incidents where we have put her into the hydro labor tub and then we have to take it out for any reason, including the third stage complications. We do conduct experience sharing on alternate birthing positions with these women, and they are very happy. And as a token of appreciation, we conduct this. So thousands of deliveries have been carried out, and we have maternal and perinatal outcome. Maternal and perinatal outcome calculated, and there is a MRI finding suggesting that when the woman is in upright position, the pelvic dimensions are more. There has been always a concern about the obstetric anal sphincter injuries, but it is said in the literature that lithotomy position is associated with highest risk of OASIs, least risk of OASI in kneeling and hands and knees position. So what we do, we give information about various birthing positions during the antenatal period. Options for their birthing position is noted down, and then we also conduct classes for birth preparedness classes in the antenatal clinic. Birthing ball training is given. Yoga maybe
Dr.
for
Bangal,
fun.
it will be
Yeah.
nice if we can conclude.
Yeah.
I
Labor
think
room tour is being
overshot by
conducted.
5 minutes.
And then there are some of the pictures of how we introduce these different techniques to the women. And this is all possible with the skill building workshops. And also we transfer this with our postgraduates where they present in different forums. That is how we want this to go ahead with the next generation. Thank you very much.
I think it has been another wonderful lecture, which I have enjoyed. I'm sure everybody else has enjoyed. There'll be lots of
Thank you.
queries and
There are
request
lots
you to
of
answer it in
questions.
the chat box.
Dr. Bengal, please answer them in the chat box. Some I
Sure,
have
sure,
answered,
sure.
but there are many.
Yes, yes, we will.
So
I
I'll
will.
move to next talks.
Yeah.
Fantastic lecture, Dr. Bengal.
Thank
And
you.
here we have Dr. Karthikeya Bhagat. He's a consultant obstetrician gynecologist, Grace Maternity Home, Baby Friendly Hospital. And he's going to speak to us on
program labor.
Program labor, yes.
Can I share my screen?
Yes, sir. Yes, sir.
At the outset, let me thank Parag and Charmila for giving me this opportunity and sharing my views with you. This is something which is very close to my heart, and I cannot not mention Dr. Daftari when I talk about program labor. Let me tell you a few stories. In Dublin, there's a national maternity hospital. There were 2 wings to this hospital, and one of the wings closed down. When the wing closed down, there was a huge burden on the second wing for delivery. And there they practiced active management of labor. And they said that by practicing active management of labor, we can reduce the congestion in the labor rooms. So what they did was they gave promise to every woman that they'll deliver them in 12 hours. It is a very scientific program that they devised. This is not the best platform to discuss all this, but I would want every obstetrician interested in management of labor to read this book called Active Management of Labor. First time we discussed was in 1973. The second story I wish to talk about is when Dr. Daftari took over as the Dean of Wadia Hospital. He studied the labor outcomes from 1988 to 1993. And he found that there were differences in the deliveries which occurred in the daytime and the deliveries which occurred in the nighttime. There was more of perinatal morbidity and mortality in the night compared to the day, and there was more of maternal morbidity in the night. So when they looked at it more closely, they realized that no, all this happens probably because there are senior consultants available in the daytime. The senior staff nurses are available in the daytime. There's more of staff available throughout the day. The blood banks are staffed well and the labs are well staffed. So they thought about it and they said, or they wondered that can we reduce the perinatal morbidity and mortality by delivering women in the daytime when the labors, when the infrastructure is better managed. The third story I wish to share is about a friend, Shruti Malvi. Dr. Shruti Malvi practices in a place called Hoshangabad, which is Narmadapuram on the banks of Narmada in Madhya Pradesh. Now, she has patients coming over from 15-kilometer radius to her place. She used to see a lot of obstetric emergencies in terms of obstructed labor, rupture uterus, bad outcomes simply because the labors were, their patients could not reach her place in time. She heard Dr. Daftari talking about program labor in 2009, and she saw an opportunity and she practiced it. And after having adopted the program labor protocol, she says her obstetric emergency has reduced. the complications she sees are much less because she admits patients who stay far away, near term, and delivers them. And the outcomes are far better. Let's talk about labor pain. Labor pain is about the worst suffering that can afflict mankind. And it is human to give pain relief to every parturient. ACOG and the American Society of Anesthesiologists state that labor results in severe pain for many women. There is no other circumstance where it is considered acceptable for a person to experience untreated severe pain, which is amenable to safe intervention while under a physician's care. And maternal request is a sufficient medical indication for pain relief during labor. So no woman should be denied pain relief in labor. And it is the duty of every obstetrician to provide pain relief to a woman in labor. Program labor is an indigenously developed protocol of labor management to be used by an obstetrician to optimize obstetric outcomes, especially in low-resource setting where an expert anesthetist may not be available. It's a simple protocol which can be implemented with confidence by any obstetrician, and it doesn't require presence of an anesthetist. Program labor basically has two parts, the onset of labor and pain relief. The labor could be spontaneous or it could be induced, and the indication for induction of labor could be varied. It could be obstetric or non-obstetric, especially in high-risk cases when you would want the patient to deliver in the daytime with infrastructure which is ready to tackle emergencies. Or you have a patient whose husband is a shippy or in the armed forces and he is available for a short period of time. Pain in labor, we said, is one of the most severe pains of mankind can experience. A woman with extreme pain will have increased sympathetic overactivity. She will hyperventilate, which will reduce the uteroplacental blood flow, which will cause maternal alkalosis, leading to vasoconstriction and ultimately fetal acidosis. To prevent all these complications to the baby, all we need to do is give pain relief to every woman in labor. So it is humane to provide pain relief to every distressed parturient in labor. What are the methods of pain relief in labor? It's basically medication or regional anesthetics. The drugs available are either inhaled anesthetics, parenteral opioids, or non-opioid drugs like paracetamol, NSAIDs, sedatives, or antispasmodics. So practically, the drugs available for pain relief and used for pain relief are either morphine or pethidine, which are given up now. Pentazocine, tramadol, diazepam is no longer used. We have midazolam instead, ketamine, fentanyl, or maybe remifentanil when it comes up, and Entonox, or now sevoflurane. As far as the regional blocks are concerned, it's perineal infiltration, pudendal block, saddle block, epidural, and a combined spinal epidural anesthesia. Let's discuss some of these techniques. Epidural labor analgesia is the best method for pain relief today. The pain relief is to the extent of 80 to 90% most of the times. However, it's a surgical procedure with inherent risks. What are the risks or the side effects? It could be patchy action, partial pain relief, severe hypotension, occasional irregular fetal hearts, headaches, partial paresis, dural punctures, and a few more. It also increases the chance of operative vaginal delivery. But it also means that you need to have a trained anesthetist available to give epidural anesthesia, which is not possible in many of the places where we practice. Entonox is basically a combination of nitrous oxide and oxygen. It is easy to use. Pain relief is just adequate, especially in early labor, but not very effective in advanced labor. There are no major side effects, but it causes a lot of nausea and vomiting. And it's not very commonly used because of the cost and the limited availability of the equipment. The drugs available to us are basically opioids have been used for a long time, but there are a lot of side effects. So they're out of vogue now. Morphine and pethidine are out of vogue. Drugs available to us are basically tramadol, pentazocine, midazolam, ketamine, fentanyl, remifentanil, sevoflurane, and inhalation anesthesia. All these drugs, when used as single agents, had to be used in a larger dose which will increase the side effects and have erratic safety profile for the baby. So program labor in protocol was developed to provide maximum pain relief with minimum side effects to everyone in labor where basic monitoring was possible, irrespective of the infrastructure. The drugs used were diazepam when it was discussed, but which we've changed to midazolam, pentazocine, tramadol, rotavirine, and ketamine. What was the logic of using protocols? The logic was by using a combination of drugs, we'll be able to reduce their doses to achieve a maximal effect or synergistic effect, to achieve the desired level of pain relief, minimizing the side effects. So you reduce the dose of drugs, so you're reducing the side effects, and you are synergistically acting using them without jeopardizing the maternal and the fetal outcomes. Midazolam is used, it's a benzodiazepine, an anxiolytic. It's used in 1/5 the dose. Pentazocine is a strong opioid, which is used in 1/5 the analgesic dose. And ketamine, a dissociative anesthetic, in 1/4 the anesthetic dose. To summarize the drugs used and their effects, the opioids we use are pentazocine and tramadol. Pentazocine and tramadol is used in 1/5 the anesthetic dose. Midazolam is used again in 1/5 the anesthetic dose. Ketamine is used in 1/4 the anesthetic dose. And antispasmodic is used. Now, how do you use these drugs? The first and foremost condition is that the patient has to be in active labor, which means that she's around 3 to 4 centimeters dilated. She's getting 3 to 4 contractions in 10 minutes, each lasting for around 30 to 40 seconds. The presenting part is vertex, the liquor is clear, and there are no contraindications to normal delivery. Once you've decided that there are no contraindications, you'll use the program labor protocol on her. But it is always better to take a consent for whatever you do. An oral consent should be taken, where the written consent is always preferred. But during labor, when the patient is in severe pain, is it the right time to take consent? No. So the best time to take consent is antenatally. So patients should be counseled in the antenatal period about pain relief. The options should be discussed. And most important, the relation should be counseled before you use the drugs on them. How do you use the protocol? So the first step is when you identify the patient in labor and you want to use the protocol, you'll use midazolam and pentazocine. Now, midazolam is available as a 10 milligram in 10 ml bulb. So which means it's available as a 1 milligram per ml bulb. Pentazocine is available in an ampule form, which is 30 milligrams. So you'll take 1 cc, 1 ml of midazolam, which is 1 milligrams, and 1 ml of pentazocine, which is 30 milligrams, in a 10 cc syringe, diluted to 10 cc with 8 cc's of distilled water. This will give you a concentration of 0.1 milligram midazolam and 3 milligram of pentazocine per ml. You inject 2 ml IV slowly. So you are using 0.2 milligrams of midazolam and 6 milligrams of pentazocine. Tell the patient that she will feel a little giddy and sleepy. At the same time, inject tramadol and rotavirine. Now, in a couple of minutes, the pain will ease out and the patient feels sleepy, especially between contractions, waking up during contractions. Monitor the fetal heart, plot the partogram. The IV dose of midazolam pentazocine acts immediately. The effect lasts for around 30 to 60 minutes. And the IM dose starts working in 30 minutes by the time the effect of the IV dose wears off. Most patients are comfortable and dilate to 7 centimeters in the next 2 to 4 hours, so that the effect, by then the effect of drug has worn off. This regimen works for almost 80% of the cases. Pain relief produced is adequate and 20% require additional pain relief after 7 centimeters and the head is on the perineum. So these are the patients where you can use ketamine. It's used in 1/4 the anesthetic dose. So you use around 12 to 20 milligrams. So you dilute 1 ml of ketamine, which is 5 milligrams, and 1 ml of midazolam, which is 0.1 milligram, and give it slowly. Most patients respond with good pain relief with 12 to 20 milligrams of ketamine, don't exceed 25 milligrams. And midazolam is used to prevent hallucinations caused by ketamine. Pain in advanced labor when the head is pounding the perineum before crowning is not taken away by any drugs or even epidural anesthesia. The only technique that works at this juncture is pudendal block. Nothing else works. This is followed by the active management of third stage of labor. What are the advantages of?
We have to conclude.
Just give me a minute. Give me a minute.
Asha madam, sir's talk is for actually 20 minutes, madam, because especially it was.
My apologies.
Yeah, sir.
My apologies, sorry.
So please continue.
All right. All right. So the advantages of program labor are significant pain relief to the patient, considerable amnesia of the painful events of labor, shorter duration of labor, which works for all of us, significant reduction in incidence of dystocias, and hence reduction in the number of cesarean sections, reduction in the number of instrumental deliveries, satisfactory perinatal outcome and maternal satisfaction, and a comfortable mother who is not exhausted, mentally alert, and eager to breastfeed her baby, which is what we want. So let me end with just 3 stories. Once I had a patient in labor who had relations in the USA, and she wanted epidural. She came in labor, she was shouting at the top of her voice and wanted epidural anesthesia. So I called up my anesthetist. He says, I've just induced a case. I'll take around an hour and a half to reach. I told the patient, but she was screaming at the top of her voice. And then I asked her, can I use something else for you? So I used the program labor protocol. In 1.5 hours, the anesthetist calls me up and tells me, okay, can I come now? I said, there's no need to come because she's almost ready for delivery. Second story involves a colleague who had a patient with thrombocytopenia, who was screaming at the top of her voice. She called the anesthetist to give epidural anesthesia. The anesthetist refused because of thrombocytopenia. And then they were in a fix. What do we do? The patient has to be given pain relief. So they called up my anesthetist, who's used to the labor anesthesia protocol. They used it on her and relieved her of pain. And the third is a personal story, which I generally don't like to share because it reflects on what I do. You are in a position in which I was 5 or maybe a couple of years ago. Dr. Daftari had been telling me about program labor for a long time, but I could never manage to use it because every time I would discuss it with my anesthetist, they would say, no, these drugs are not to be used by you. So once we had to go for a program at Palghar, which is 80 kilometers away from Mumbai. He said, Dr. Daftari said, I'll pick you up. So he came to my place and I had a patient in labor. So I told him, sir, I have a patient in labor. How can I go? He says, okay, no problem. Can I see her? How could I refuse? So I let him see her. He says, can I use the protocol on her? I didn't have a choice. So I said, yes. So he used the protocol and he said, now give me a cup of tea. I've come far. So we had a cup of tea. In an hour and a half, he said, now let's go and see your patients. She was 7 centimeters dilated. She delivered in the next half an hour. And we left for the Palghar symposium and we completed it. All that happened was fine, but it changed me for life. And since then, I've been using the protocol. So I believe you are also in the same state. But you're not as lucky as me to have Dr. Daftari do it for you in front of your eyes. So you'll ask me, how do you know that it works? So there's enough literature available. You can check it out. There is a ICOG, there is a copy of the Indian experience in the ICOG website, and there are multiple things available. Thank you so much.
Thank you, sir. So we have grown up listening to
Sharmila.
program labor. That's why we wanted you to
No,
talk.
no, it's very close to my heart. And Charmila, if you allow me,
Yes, sir.
I have a small video because now if you use the video, then
Okay.
probably people will get an idea. So if you give me 5 minutes, I can use the video. Otherwise, we can just omit it. That is not a problem.
Can we do it after the panel discussion, sir? Is it possible? Can you join back
And
again?
probably people will miss out. This is fresh now. So just 5 minutes.
Okay. 5 minutes then. Okay. Parag is not there, so we'll do
Okay,
it.
I'm relieved. I'm relieved. Parag is not there. This is a patient in labor.
But in a diluted form at 1 treat and give only 2 cc, that is 1/5 of this.
This is immediately after injecting the.
So we're not seeing the video. We're not seeing the video.
Oh,
it's not playing.
Oh, how do I do it then?
You can see here the patient has wiring down after
you have to share the video screen.
You have to tick the yes.
Now I'll play the video.
Hmm.
It should be seen now, no? If I'm sharing my screen.
No, you have to go to share and check. No,
So it's screen.
You have to stop sharing your audio and go for video.
Double click for the video.
How do I do it then?
Double click.
Double click here. Is it seen now?
No, sir.
No.
All right, then let's leave it out. I
Okay.
think it's a waste of time. I would have shown you. This was a video which was taken during the Varanasi workshop on program labor. It shows the patient in labor. It shows how the protocol was used and how quiet she becomes and how she delivers. So
can you send the video to Nilima, ICOG?
Right.
Then we can share from
I
there.
will share it with you so the participants can have a look at it.
Okay, sir.
Thank you so much, Sharmila.
Thank you, sir. Thank you, sir.
Thank you so much, Dr. Bhagat.
Thank you.
It was a highly educative talk. Enjoyed the talk. Thank you.
Yes. So now to the final session of today's program. It's going to be a panel discussion on induction of labor to be coordinated by Dr. Poonam Goyal and Dr. Sneha Buer. Poonam Goyal doesn't need any introduction. She's already there for the past 2 hours. Now, Dr. Sneha Buer, she's a practicing OB-GYN and she was the breast committee chairperson. So, madam, you are going to coordinate this panel. And we have 4 panelists. Dr. Sushma Dev from Aishwarya Hospital, Mysore. We have Dr. Indra Chandana, Director, Chandana Medical Center, Faridabad. And we have Dr. Farina Begum from Syed Ammal Trust Hospital, IVF Center. And we have Dr. P. Shankari from NRK Specialty Hospital, Pudukkottai, Tamil Nadu. So over to the panel, coordinators and the panelists. It is going to be a wonderful discussion. Looking forward. Because always labor, induction of labor is an enigma and it keeps changing from time to time. Over to you.
Yeah, thank you so much, Dr. Umayya. A very good evening to all of you. And let me just thank
Snega, one second. I'm sorry for interrupting. The time should be kept more. It's a panel discussion. I'm telling the tech team. Keep the correct time limit, please, for the panel discussion. Yeah. Thank you, Snega. Please.
Yeah, 45 minutes.
45 minutes.
40 minutes.
Yeah, I hope you can see the slides.
Will be okay. Yes.
Yeah, so we have been listening to the various birthing positions and the changing techniques, and right from program labor, we have been listening to all these talks. But what if the lady doesn't go into spontaneous labor, if there is a need to initiate uterine contractions or maybe induce labor? So what is the practice and what is the evidence? What are the recommendations as per the FOGSI ICOG? You can see on this side, FOGSI EEBR, that is Ethical Evidence-Based Recommendations for Induction of Labor. So this is uploaded on the website, and I'm request all of you to go through by the time we go for this discussion. So friends, what is the
induction of labor. You can just, so this is all of you know what is, hello.
Also Monday evening.
Yeah, so I hope all the panelists are here, and can you please, put your video on so that we can trace you easily. So it is the term is self-explanatory, induction of labor. That means to initiate the uterine contractions, which are not there already. The patient is not in spontaneous labor. So what is the timing, what is the gestational age, what is the exact indications, and what are all the agents used, what are the complications, all these aspects we are going to cover this in detail. So this process is indicated in situations where the continuation of pregnancy may jeopardize the mother, the baby, or maybe the both. And this is widespread use of labor induction in low-risk pregnancies after the arrived trial, after a shared decision making. So can we have in short the various terminologies clear from each of the panelists? So what is the Bishop score and what is ripening? Can we have from Sushma, Dr. Sushma Dev?
Very good evening, everyone. Firstly, I would like to thank Charmila ma'am and Sneha ma'am and Poonam Goyal ma'am for the opportunity. It's a great pleasure and honor to be part of this ICOG program. Induction of labor, which we are doing from the day-to-day practice. This is the process wherein we induce artificial stimulation of the uterine contractions in a woman, pregnant woman who is not in labor.
Yeah, Dr. Sushma, we just, I think, can
you hear me? A lot of disturbance.
Others? Nilima, can we mute others? Yeah, Dr. Sushma, we have finished with the introduction. Can we have the terminologies clear? What is Bishop score? What is cervical ripening? Yeah, so you can start with what is Bishop score. Yeah.
Bishop score is a very important thing, that this gives us the notion that whether the woman is going to have success of the vaginal delivery. So in this, we are having a modified Bishop score where we are going to take in the cervical dilatations, the length of the cervix, the consistency of the cervix, and the stations, and the score above 6 is considered to be more positive, and we have a probability that this woman will going to have a success of induction of labor, prompting to be having a vaginal delivery.
Correct. So this is the most important aspect, because whether the induction will be successful or no, the most important determinant is Bishop score. So let us go ahead, Dr. Kiran. What is cervical ripening? Do we have Dr. Kiran?
Yes,
or Dr. Sankari, we can have from you.
Dr. Kiran is there.
In the cervical ripening, the cervix is soft and it is the length of cervix is less, and it is soft and it is easily dilatable.
Correct. So various characteristics, there are various remodeling, stretching, and the elastic rearrangement. So all these changes, we define it as cervical ripening. So Dr. Sankari, can we hear from you what is tachysystole, and what is hypertonus, and what is hyperstimulation?
Yes, ma'am. The goal of labor induction is to achieve a contraction of 3 to 4 in 10 minutes, and each lasting for 30 to 40 seconds. But when we have an increased number of contractions, say like 5 contractions in 10 minutes, we call it as a tachysystole. And when hyperstimulation, and when the tachysystole, when each contraction lasts for more than 2 minutes, we call it as hypertonus.
Right. And hyperstimulation
when we have both either the tachysystole or the hypertonus contractions along with CTG abnormalities, we call it as
right. Now that we have decided to induce this lady, how long should we wait? When do you call it as failed induction?
Actually, to say correctly, there is no definitive time interval to call it as a failed induction, but various studies give a different thing. But the main thing is not to include the cervical ripening time in the definition of failed induction. Ideally, the definition should include the rupture of membranes and the oxytocin infusion at least for 12 hours to call it as a failed induction. or it may be according to the gels, number of prostaglandin E2 gel we keep, a minimum of 3 gels in 24 hours, or one PGE2 insert, 10 milligram in 24 hours. We call it as failed induction.
Yeah, so we are coming to the detailed agents to be discussed little later. So Dr. Sushma, can we have from you, before going for induction of labor, what are the prerequisites? How you will go about it?
Yeah, very importantly, whenever we plan an induction of labor, we have to consider, is the patient, what is the indication? Is the patient's gestational age is correct to induce the labor, whether she has achieved a term pregnancy. But in cases of high risk pregnancy, we have to consider the gestations for the fetal viability and also the maternal indications. Most importantly, you have to rule out whether we can leave this woman for the vaginal delivery. That is, the adequacy of the pelvis is very important, and also the presentation of the fetus, whether it is cephalic and non-cephalic, all these things to be done. And very importantly, as we discussed, the Bishop score. And whenever we plan an induction of labor, we have to have a detailed discussion with the patients. We have to sit across the couple and tell them how exactly we are going about with the induction of labor, what are the pros and cons. Of course, we have to explain.
Yes, go ahead. So basically, you have about all these indications, exact gestational age, and all these details. But first thing, what we have to clarify that there is no contraindication for vaginal delivery, because your very essence or very aim of this induction is vaginal, to attempt the vaginal delivery. But on this other hand, you have to explain the patient and relatives that there is no surety that she will deliver vaginally, and it's her sincere attempt to induce her, make her go into labor, and our aim is of course to achieve vaginal delivery. But anytime she can land up into complications or cesarean section, and for that we have to have an informed written consent. So very
we should
well
be
said.
discussing the realistic situations, because often the patient comes with an assumption that once we induce, there will be 100% vaginal delivery. So we have to be more realistic.
Right. So Dr. Kiran?
Yes, ma'am.
Yeah. So, what are the possible complications of indication?
The complications can be fetal complication, and there can be maternal complication.
Right.
And the fetal complication, there can be iatrogenic prematurity, there can be fetal hypoxia, sometimes fetal distress also. And such patients, they have got meconium staining liquor also, and they have more NICU admissions, and they have fetal hypoxia, hyperbilirubinemia also in such patients. And in the maternal condition, there can be failed induction, there can be prolonged labor, more pain, and sometimes they have cord prolapse while we are doing the amniotomy. There can be abruptio placenta, there can be increased analgesia requirement in the pregnancy, more operative deliveries in such patients. And such patients, they get exhausted
Because
tone,
this is basically a induced labor. The course also can be protracted, and it can be more painful than the natural labor. That has to be explained. And the end results there can be some complications with the mother or the fetus. That has to be explained very well. And of course, what we have already talked about, either the induction can fail or she can land up into operative intervention. So with this basic sensitization, we now come to the case discussions. I think Dr. Poonam, do you want to go ahead with the case discussion?
Okay.
Yeah.
So Dr. Farina, we have a patient who is optimized, means non-high risk patient, primary 37 weeks with good pelvis, average size, non-compromised baby, cervix is long, uneffaced, and head is at still -2 station. Wants to time her delivery for some personal reason. So how do you take this? Should we be entertaining her wish or not? Dr. Farina, are you there? I saw she was.
Good evening, ma'am. Can you hear me?
Yes, absolutely.
Good evening, ma'am. Thanks for the opportunity. First of all, I see she's a low risk woman. I still want to take a detailed history, past medical and surgical, and I want to conduct a detailed general as well as a good physical examination and an obstetric examination. I want to know her age and her previous scan reports, and I want to confirm her dates as well. Once I'm sure of all this, I will look at her investigation reports, and for growth scan, the latest scan, and her vitals are stable. I would like to sit and discuss with the patient why she wants induction of labor now. Even if the reason is genuine, I would like to convince her to the fullest of my ability to continue her pregnancy. I will try to give her every opportunity for her to go into spontaneous labor. Even in the place I practice, many patients they do not want to deliver in particular months for auspicious reasons. But I at least try to pull them to full term and then only induce them. For her, I would like to convince her. I will tell her about the risks of inducing her now with her unfavorable cervix. If I induce her now, there is high chances that she might land up in a C-section. So I would like to tell her all those things, and I'll try to convince her. Then now she's 37 weeks.
Yeah,
So
Dr. Farina, I would just interrupt you a little. 37 weeks, long uneffaced cervix. I think both these points are going against, it is just her wish. So that is how I think it's our duty to explain her what are the pros and what are the cons of induction, right?
Yes,
so if at all, just because we are doing some unnecessary intervention here, she can land up into complications. So we must inform her, and if at all she stresses, we have to take an informed written consent and then go ahead, right?
Yes, ma'am. Yes, ma'am.
Okay.
If the patient keeps on insisting, we are not left with option. We have to get an informed written consent and then proceed.
Right. So, anything else you want to add here?
Ma'am, regarding when to induce her, I'm going to prolong her pregnancy. There are mixed opinions. The foreign bodies, the NICE, they are telling to wait till 42 weeks for nature to take its course.
Yeah.
But the NICE article itself states clearly that the risk of stillbirth, cesarean section, and neonatal morbidity is clear-cut higher after 41 weeks. And also the same article stresses that the stillbirth rate is 50% higher in the Asian population in the UK. So we cannot extrapolate the foreign guidelines to India. I strongly believe more than 40 weeks is no for people from
India. Yes, I also
in fact, majority of these organizations unanimously they accept that the stillbirth rates are higher after 39 weeks, and that is why they have come to the conclusion that if at all we plan an elective induction, it should be beyond 39 weeks. So you can see here the references which are there from ARRIVE trial, 39 to 41 weeks. WHO guideline also says the similar, but FOGSI ICOG GCPR 2018 and FIGO 23, NICE guidelines and SOGC, all of them, they said, that we can go ahead for induction of labor only after 39 weeks. So that is how for this patient, basically when absolutely you do not have any maternal or fetal indication, given a choice, we should try and convince her not to go ahead. If at all she insists, then maybe we have to wait till 39 weeks, or then as the discussion goes ahead, we have to first go for ripening of the cervix and then go ahead with the induction of labor. So we have this second case now.
Prime gravida, 38 to 39 weeks gestation, and you have educated and now decided to induce her. So how do you assess and prepare the patient before the induction, and what are the important points which you need to mention in the consent? Dr. Shankari, please.
Yes, ma'am. So as already stated, though the various Western guidelines say we can go till 41 weeks, it cannot be, followed here because of the increase of perinatal mortality and morbidity beyond 39 weeks. And as rightly said, the FOGSI EBR states induction around 39 weeks. So first and foremost thing here, you have to confirm the gestational age from the dating scans, because iatrogenic prematurity cannot be accepted at any point because of induction of labor. And once the case has been evaluated, we have a certain combination of factors to decide the success rate of induction of labor, like the weight of the patient, BMI, with nulliparity, whether she has the Bishop score mainly, when the favorably score of more than 6 or more than or equal to 6, we have a good outcome and a shorter induction to delivery interval. And once we have evaluated, the first thing is to rule out contraindications for vaginal delivery and whether we have any proper indication for delivery at this gestation age, because it is 38 to 39 weeks. And once we assess the patient for pelvimetry and the fetal well-being from the recent scans, like for estimated fetal weight, placental position, Doppler studies, and amniotic fluid index, and we can go ahead with the induction. And the first thing to do is to sit and talk with the patient. And as already stated, give her a realistic view of what is going to happen when she is induced. It is not that she is going to deliver within 6 or 12 hours. So we have the options for induction, explain and discuss with her. And when we talk about the consent, always say about the failure of induction, failed induction and cesarean section and need for NICU admission. Because always when we induce, it is not that 100% we are going to get a normal delivery, vaginal delivery, say. So we have to take a proper consent and preferably written informed consent in our own, local language, which she is preferably understanding. Okay.
Right. Right. So, Dr. Sushma, coming to you, as you have already said, what is ripening? So, ripening is the most important, parameter, as we have said, Bishop score. So, we have to have an inducible cervix. So, what are the ripening agents available, and how should we choose? Please unmute yourself.
Muted.
Unmute yourself.
Currently, we have multiple agents to induce to ripen the cervix. The most commonly what we use are the pharmacological agents. So that we use PGE2 gel, and then we have our own oxytocin itself can be used, and misoprostols. We have a controversy around that, and most safer so that to avoid the complications of hyperstimulations. So the promising things are the mechanical methods where we use the balloon catheters, the Foley's, or we have Cook's catheter and all those things. And also the older days, like currently
Dr. Sushma,
also
I
we
think you
have
said
the
pharmacological agents. Pharmacological agents are the preferred one. So is it now you're saying mechanical? So which one do you prefer, and how do you choose that?
So especially if she is a primary para with unfavorable cervix, and she doesn't have much higher risk factors like preeclampsia, and when you can buy a good amount of time when you want to induce labor, and you can wait for more than 24 hours. So I would initially go ahead with the mechanical method of inductions, and then after that probably sometimes we combine different methods. Different methods of 2 methods of inductions can be combined. So we commonly use Foley's catheter, and we inflate it to 50 cc, and we leave it for minimum of 12 hours to up to 24 hours so that she'll have expulsion spontaneously. And after that, we consider giving a cerviprime depending assessing her Bishop scores.
So I think before going to the pharmacological agents, should we go ahead with the mechanical measures if at all? Because this is not an emergency. There is no emergency. So Dr. Kiran, do you want to throw some light on this? Any mechanical method you want to, like sweeping of membranes, and then you said the balloon catheter. Any other, any herbal or any other method you know of?
We can ask the patient to have like herbal method. The patient, they are taking enema also, they are taking castor oil also, and breast stimulation can be done also, and the sweeping and stretching can be done in such patient, and the rest prostaglandins, they can be used.
Yeah, so sweeping of membranes, as you have said, there are the balloon, you have the single balloon, the Foley's catheter, and the double balloon as well. So many of these, obstetricians, they have been practicing and using these devices quite regularly. Then we come to the prostaglandins. Now you tell me, Dr. Shankari, or Dr. Farina, I think, how do you choose those prostaglandins? Any contraindications to be used for this?
My first choice would be mechanical induction as discussed.
Yeah.
After mechanical, I usually use the Foley's for mechanical induction.
Right.
After the Foley expels or after 12 to 12 hours, I don't wait usually till 24 hours. I do a pervaginal examination and then I reassess the Bishop score and then decide which prostaglandin to use.
Yeah, but
We have
suppose with
E1 and E2.
yeah, suppose with Foley's you don't get the adequate contraction. Then do you start oxytocin with the Foley's in situ?
Usually I don't use with the
Yes.
Foley.
In fact, this is what is the advantage, that for mechanical methods, you don't have much of risk, and you don't have the risk of hyperstimulation as well. Okay, so with the Foley's catheter in situ, you can definitely start with the oxytocin infusion when you feel that the cervix is now become favorable, right? On the other hand, when you're using prostaglandins of any kind, you have to wait for certain period. So we come to the details of it. Now, Shankari, suppose you're using a misoprostol tablet. How do you use? What is the dosage? How frequently should you use the tablets? And what is the route of
There's a controversy around this misoprostol tablet use, and though the FOGSI EBR recommends misoprostol use, NHM guidelines which is given to us doesn't recommend misoprostol.
25 microgram,
But
right?
if all we have to use, then we have the choice of oral and vaginal route. Or a vaginal route of 25 micrograms for every fourth hourly can be repeated, and oral 25. And oral of 50 micrograms 2 hourly can be repeated. However, there are certain contraindications for the use of misoprostol, like scarred uterus, where you have to be cautious. And there are chances of hyperstimulation and even
Even the asthma. When a patient has asthma or some
contraindications for misoprostol always.
Yeah. Okay, so suppose you're using the misoprostol tablet, maybe vaginally. You have already said that maybe 3 to 6 hours, this can be the time duration, this can be the frequency of insertion of the tablet. Depending upon the response, maybe you will titrate the timing of insertion. But suppose she's not responding well to this misoprostol tablet. Now, when do you say that it is a failure? And when do you want to start oxytocin? After how many hours?
Minimum of 4 hours after the last dose of misoprostol should be given to start oxytocin trip. And
Correct, you're right. So, Dr. Shankari, what about the dinoprostone gel? How much do you use? How frequently? What is the total dosage?
Dinoprostol gel, PGE2 gel, which we use, comes in 2.5 ml tubes, and it is around 0.5 milligrams. And we are allowed to use up to 3 gels in 24 hours.
Yeah.
And 6 hourly interval, we can use the gels.
Right. And suppose you have to use the vaginal insert. When do you say, yes, when do you say it has failed? And how long should you wait before starting or changing?
Wait for 24 hours for the insert, like 10 milligram insert can be kept up to 24 hours. And if we tend to see any hyperstimulation, or if she is not comfortable, the only advantage is that we can remove it whenever we.
Yes, but if you have to, it's a time release preparation, right? It's a time release preparation, 0.3 milligram per minute. So you have quite a few alternatives, as we have already talked about. We have seen how you can choose. Sublingual administration is also possible, though we don't use it quite routinely, because it says that the bioavailability is good, because it bypasses the first pass effect. Serviprime or the dinoprostone jelly we have already discussed, and this is the Servitil, which is available as an insert, which is a time release device, as we have already said that it releases 0.3 milligram per hour. And if at all the patient has hyperstimulation, you can definitely remove this, and you can get that the contractions are again lesser, and you can avoid the hyperstimulation or maybe even the rupture of uterus. Oxytocin can be initiated beyond 30 minutes after removal of this insert, when we are talking about the failure of induction with this. Okay, so I think what is the dosage of oxytocin? How all of you are using it as a routine? What is the drip rate? What is the infusion concentration? Who wants to take up this?
Dr. Farina, Dr. Farina.
Yes, ma'am.
Yes, Farina.
Oxytocin is available as 1 ml ampule, which contains 5 units. So
Yeah.
I usually advise the staff to give it through an infusion pump only, because we cannot control the rate through a normal drip. So I strictly insist them regarding the infusion drip, to use the infusion drip. How we use is, we take 1 ml of syntocinon and we put it in a isotonic drip, either an RL or an NS, 500 ml of drip, which means 500 ml of the fluid will contain 5 units of syntocinon. So 1 ml will contain 1 milli international units.
10 milli international units. 1 ml is 10 milli units. And 1 ml is 16 drops, right?
Yes, yes. 1 ml is 1 by 100, which is 1 milli international units, which is equal to 16 drops. There are two protocols, low dose and high dose protocol. I prefer low dose protocol most of the times. And sister, I tell the drop rate usually. They usually start at 0.5 milli international units, which is 8 drops per minute. And every 30 minutes, I will ask the staff to check the contraction. If we have achieved the target contraction, I usually maintain the same dose of syntocinon. If the target contraction, that is 3 in 10 minutes, with lasting for 40 seconds, is not achieved, I ask them to keep increasing the drop rate to every plus 8 drops every 30 minutes. I maximum to 64 drops per minute.
Right. So, Dr. Sushma, when do we label this as failure of induction with oxytocin infusion?
So we can go maximum of 12 hours with oxytocins, and with the lady, if she doesn't enter into active labor and she doesn't get adequate uterine contractions as we expect, so we have to label her as failure of inductions. And after the oxytocin, we are not left with a better choice. And we have to be in concurrence with the patients to discuss the next course of labor. And more importantly, we have to look into the how is the contractions, and also the fetal monitoring is important whenever we are doing the oxytocin infusions.
Yes. So how do you monitor the patient who is being induced? Because when you are giving oxytocin, she is basically now automatically becomes a high risk woman in labor.
Yeah.
So how do you
Ideal
monitor?
would be it's a electronic fetal monitor.
Yes, electronic fetal monitoring.
Right. How frequently, when we are talking about, when we are considering her as high risk woman in labor, so how frequently do you want to monitor her? In various stages, you can say.
Yes, ma'am. Whenever we start induction of labor, we need to start with an baseline CTG to know the baseline pattern of that fetus. And when we go with mechanical methods, we generally do not advocate this continuous electronic fetal monitoring. But once she goes into labor, like in the first stage of labor, we need to monitor at least once in 30 minutes. But guideline says 15 minutes, once in 15 minutes.
Yeah, for a high-risk woman, it is once in 15
we have to go with the continuous electronic fetal monitoring. And once the oxytocin is started, then she falls into high-risk category. Yes. And we need to go for continuous electronic fetal monitoring.
And what about the second stage, if at all?
Once in 5 minutes, and each
following every contraction.
1 minute following the contraction.
Right. So as you rightly said, before starting the induction of labor, as you rightly pointed out, that mechanical methods do not need a continuous monitoring. Intermittent auscultation and monitoring should be good enough. But after vaginal prostaglandins and even after the oxytocin infusion, definitely we have to consider her as high risk and monitor her with continuous electronic fetal monitoring. Over to you, Poonam. You can take the discussion.
Yes. So next question is for Dr. Sushma. So it's a primigravida, 37 weeks of gestation, who comes to us with frac leaking. So how do we proceed? Should we be waiting for spontaneous labor to happen? And if we wait, for how long we will wait? Or should we immediately start induction of labor, seeing that she has leaking already?
So as previously discussed, we have confirmed that she has had a term premature rupture of membranes, and after that, we have to terminate the pregnancy. We have to induce labor because currently, as per the FOGSI and FIGO, it's ideal to go ahead with the active induction of the labor. Generally, in our practice, we wait for 4 to 6 hours and allow for the spontaneous labor to onset, and accordingly we decide the next method of inductions. But few guidelines say even up to 24 hours, if she doesn't have any other contraindications and the maternal and the fetal conditions are fairly good, we can even wait up to 24 hours and allow for the spontaneous labor. But it would be ideal that we consider method of inductions as early as 4 to 6 hours. That would be our practice.
Yeah,
So I
think everything you have covered, except that there is no signs of sepsis either to the mother as such. She doesn't have any focus of infection, or there are no signs of infection. Otherwise, we have to take the decision fast. So if you have the rupture of membranes, expectant management can be, you can wait up to 96 hours, provided everything is normal and you feel that, cervix is not ripe and it is you are ready to wait for ripening and then induction. So, but then you have to be alert as far as the chorioamnionitis part is concerned. As we all of us have already discussed, these are the various measures for induction of labor. So this is a chart just showing you that low risk, if at all she is, you have to confirm that she is 37 weeks and not less than 34 weeks. So you have to, if it is before 34 weeks, basically you have to be little expectant in the management. 34 to 37 weeks, in the absence of intrauterine infection, you can wait, as we discussed, up to 96 hours. But induction of labor is offered earlier if there is any sign of infection or fetal compromise, or maybe even the maternal condition is worsening because of some other problem. So to you, Poonam.
So, Dr. Channa, patient is Gravida 3, Para 1, Abortion 1, and her previous was LSCS birth. Now she is having a 34 weeks IUD. So now how will you proceed? Will it be expectant management, or will it be what counseling you will do, and how will you investigate, and what will be your approach?
So because this is IUD patient and this is she is 34 weeks and previous LSS and no recurrent cause, first I will investigate whether the patient is having any sepsis, any leaking PV, any abruptio placenta, or in which we have to induce her immediately. If there's no such condition, then we can just wait and watch, and we have to, in the meantime, we have to counsel the patient about this grief. She has to handle this grief also, and after that we have to see that whether the patient what was the delivery interval between the two deliveries, two pregnancies. If it is just 1 year or 1.5 years, then we can think of a short trial of labor by the mechanical. We can just give the trial of labor, but we have to be very cautious about the scar thickness also, and we have to think about the cesarean delivery. But if there's long time between the two deliveries, then we can think of the vaginal delivery in such cases. And if we are waiting for the expectant management is being done, then we have to do the coagulation test twice weekly has to be done so as to avoid the DIC. And the induction can be done by doing the Foley's catheter also, or we can do the mifepristone can be used for such patients. In mechanical ventilation, we are not going to have much of the hyperstimulation that is going to help such patients.
I think mechanical will be good.
Yeah, basically when you have previous one scar, and when this baby is lost already, so our aim will be, as far as possible, wait for the vaginal delivery. I mean, try for the vaginal delivery, as Dr. Kiran has rightly pointed out, provided the maternal condition is stable. So she's not developing any infection, as well as coagulation, coagulopathy. That is what we have to monitor. Of course, meanwhile, she needs a lot of emotional support and encouragement, motivation, that if at all, because our aim will be to deliver vaginally, try and avoid one more scar so that, she can go for the next pregnancy. So,
next case is for Dr.
yeah.
Farina, a primea gravida, 34 weeks gestation with cephalic presentation. She complains of itching and diagnosed as a case of IHCP, hepatic enzymes borderline raised. Will you admit her? Will you induce her? Will you wait? And how will you exactly proceed with patients with IHCP?
Yes, ma'am. So intrahepatic cholestasis with pregnancy, I feel, is on the rise nowadays. It's definitely on the rise. These patients, she's a diagnosed case, so I'd like to know about the serum bile acids level for her. And I also see her hepatic enzymes are borderline raised. I will double check her blood pressure and urine albumin because these patients are at risk of preeclampsia. And they're also at risk of gestation diabetes.
Yeah,
So I'll
Dr. Farina, Dr. Farina, can I interrupt you for a moment?
Yes,
By the time, I think bile acid, we are not having the investigation very readily reported, right? So we have to wait for some time to get the investigation report. By the time you start her on some medication, and what is that and how does it help?
We can start her on ursodeoxycholic acid. It will help in the pruritus. Also, we should give antihistaminics and aqueous menthol creams for supportive management. As such, specific medicine is concerned, ursodeoxycholic acid is a drug of choice, but it is proven that it will not prevent stillbirth, but still it can help in reducing the bile acid level. What happens when the bile acid level rises is it will cause fetal anoxia and stillbirth. So we are worried about that. So we have to keep fetal surveillance also should be very strict. Based on the bile acid level, we can stratify them as mild, moderate, and severe ICP. For severe ICP, the levels are more than 100. For such patients, severe ICP, we have to induce by 36 weeks. And for moderate ICP, that is the levels are between 40 to 99 micromoles per liter, we will induce at 38 weeks. And mild ICP, which is the levels are less than 39, more than 20, we will wait even till 39 weeks. So the induction of labor is based on the stratification of the case. And as I already told, there is a risk of preeclampsia, GDM, and these patients can go for DIC as well. So we have to keep a check on the coagulation profile also. Yes. Again, regarding induction, timing is very important. And when they are in labor, if it's a severe ICP, it's better we put her on continuous electronic monitoring. Otherwise, intermittent fetal surveillance will do. And they are at risk of meconium stained amniotic fluid as well. So fetal surveillance is very important. And the stillbirth rate is higher only after 36 and 37 weeks. So we should not do a preterm induction just for the sake of ICP.
Perfect. That is what the message we want to give. Even when the levels are very highly elevated, that is an indication for induction of labor, but that too preferably after 36 weeks. Try to pull on the pregnancy till 36 weeks. And of course, if it is moderate, try to pull it till 38 weeks. 34 weeks, definitely you will not go for induction of labor for this fetus. Right.
There is one question in the chat box just popped up that they are saying that the bile acid level should be done fasting. No need to do the fasting bile acid levels with just Dr. Farina has mentioned the levels. They are non-fasting bile acid levels. So go ahead. So now this is for Dr. Shankari, hyperglycemia in pregnancy, well-controlled GDM on this nutritional therapy, and there is no complication. Induction of labor after 39 weeks of gestation. And then how do you manage the hyperglycemia in pregnancy?
Even with well-controlled GDM, there are chances of increased risk of shoulder dystocia and perinatal mortality once she crosses 39 weeks, even with well-controlled GDM. And there is also increased risk of respiratory morbidities in the fetus.
But that will be only when the patient has macrosomia, right?
Yes. We have to weigh between both the benefits and the risks, and we have to cover her with lung maturity steroid coverage, adjusting for her blood sugar levels, even with GDM. And once if it is controlled on multinutritional therapy and with no complications, she can be induced after 39 weeks. And if she is on OHS or insulin, then we have to offer induction between 38 to 39 weeks, considering all the risk factors during labor and monitoring her with hourly blood glucose during labor. And if she's poorly controlled or associated with other comorbidities like gestational hypertension or previous bad obstetric history or stillbirth, then the plan of management should be individualized and tailored, and it should not be prolonged beyond 37 weeks in the case of poorly controlled and other comorbid condition associated. And the role of cesarean section here is we can weight up to 4 kgs theoretically, but above 3.5 kg itself, we have seen shoulder dystocia cases even in well-controlled GDM patients. So we have to be cautious when we are deciding about cesarean section in GDM patients.
Poonam, the time is over. Huh? We have to wrap it
I
up.
think we'll have one message from each of our panelists for especially in induction of labor patients, and then last line, Dr. Sneha, you can take up.
Yeah.
So Dr. Kiran, your message for induction of labor.
We have to avoid the prematurity in case of when we are inducing the situation.
Absolutely right. Dr. Farina?
I'm against the waiting beyond 40 weeks and blanket induction at 39. I think at least we should wait till the EDD of the patient for a low risk primary, and we should prefer mechanical methods of induction more in our practice. That's my message.
Dr. Shankari?
Actually, counseling the patient and prenatal counseling, even before she goes into labor or till she reaches the term, we have to adequately counsel her and give her options of birth, like induction of labor and other options, whatever is available, and make her choose the options when she is not in the stress condition. So that
Dr. Sushma?
Yeah, presently nowadays the patient's request of elective C-sections are raising, and we obstetricians, we should encourage all our patients to deliver vaginally and never forget the art of for her to cherish the feel of the normal labor. And for that we have to be motivated, and we have to consider and take the couple into confidence, and we ideally induction should be offered to all primary paras, and we have to make it a very realistic practice, and inductions at 40 weeks should be. So elective induction of labor should also be considered, and counseling and medical legal practice of obstetrics, we have to be very cautious.
I think very pertinent messages from all our panelists. So Dr. Sneha, please,
Yes,
your last
I think
line.
all of them have covered almost every point. I would say that one by one they have covered everything. I would just say that, the indication for induction has to be well justified, and there should be no contraindication for vaginal delivery. That should be made sure. Of course, the gestational age has to be confirmed once again, just before going ahead with the induction. As we have already said that, you have to sit with the patient and the relatives, tell them what is the procedure exactly, tell them what are the pros and cons, how long it is going to take, how painful it is going to be, and you're not sure about the outcome, whether there can be any complications or whether she will land up into operative intervention. That has to be informed, discussed, and taken as an informed written consent. And then, of course, we have to try with all the authenticated methods of indication, as you rightly pointed out. Mechanical induction on priority. Of course, if she is not responding and the induction is quickly needed, then of course go for the pharmacological methods. Has to be used very judiciously, and the monitoring has to be very, very vigilant to achieve the success. So, the mother is happy and the baby is also happy along with the obstetrician. So thank you so much once again. Thank you ICOG, Dr. Parag Biniwale, Dr. Sarita, and thank you Dr. Charmila for having us here. And thank you all my panelists for the wonderful discussion. Thanks dear Poonam for the invite. Thank you so much once again.
All of you were surprised at the panelists, no? All of them young, different parts of the country, and wonderful speakers. They will be the future of FOGSI. That's what I'm saying. All four of them.
Thank you, ma'am.
Thank you,
So
Charmila.
we can now move for our, that
Post-test, yeah.
post-test.
Nilima will be putting the link, I think.
Okay, okay.
The link is on. Please put the timer.
In the link is in the chat box also. So I think time is up.
People would like to have the answers, or it's okay if we wrap it up. It's your choice. Yeah, Poonam? Tell them to put
Yeah, I think people are
answer.
asking for the answers. People are asking for the answers.
Okay, okay. Okay. All asking, need answers. Okay, fine.
Yeah.
To make it into a bigger screen, I think. Visible. Yeah.
Yes, Dr. Shraddha, it can be. Some are very easy questions.
That AI think only you have to listen, actually read for some time. AI.
Dr. Shanti, I think the time is up. That is why it is not accepting.
Do it little fast.
You have to be very fast. After 10 minutes, it will stop accepting. Dr. Poonam.
Parag, we finished on time almost.
On time. Almost to chalega, sir.
No, he said 7 o'clock, so we took some time.
Okay, so thank you very much, all of you, for being here so late. I know it is 15 minutes beyond the scheduled time, but I think the interesting discussion was worth it, and I am sure all of you will agree that all the presentations were informative, and of course the panel discussion was also very clinically oriented and interesting. So, on behalf of ICOG, thank you once again to our conveners, Dr. Charmila, Dr. Poonam, Dr. Rashmi, and the three coordinators, Dr. Umayyar in particular, who managed everything today. And we will see you again soon, that is 24 hours, less than 24 hours from now, for the second day. Please don't forget to attend all 3 days, and you have to attempt all 3 post-test and secure more than 50% marks in order to receive certificate from ICOG. So
People
have a
missed
good
the
evening.
time limit in the test, and so they have not been able to do that.
The questions are
Simple.
They have to be quick. Next time we'll stress it.
Poonam, just tell the 5 answers, the first 5 questions. They're keeping on asking for that.
First is E, second is
No,
C.
tell the answer.
Answer I'm telling. I have written D, C, D, B.
No, they want the answer.
I don't remember the question. Answer I'm telling. First question is answer E. Question second is answer C. Question third is answer D. Question 4 is answer B. Question 5 is again D.
There are some people who have logged in just now, but then now.
I was admitting people even now, last minute. See, now also.
Anyway, thank you very much. Have a good evening.
Thank you, Parag. Thank you so much for the opportunity. Thank you. Thank you, Poonam. Thank you, Umayyar. Thank you, Poonam and Umayyar. Both of you did so well. Thank you so much for all.
For the opportunity.
Both of you did so well. Thank you so much.
You can think of giving 15 minutes for paper.
Okay.
5 minutes extra because labor is little difficult for them to this thing. They have to go through the